Good morning, everyone, and welcome back to day two. I think we're all on the same page, and I think I speak for all when I say day one was a resounding success based on the reflection and remarks that I've heard. And day two, of course, we will pick up the pace that we left off with yesterday and blow ahead full steam for day two as well, a packed agenda as well with many more fireside chats and panels to come. Day two is therefore initially launched, and I'm extremely delighted to do it together because the topic of day two, the topic of rather the fireside chat now is the presidencies of the G20 and G7 stronger together ? And I'm extremely delighted to be joined here on stage by the permanent representatives to the UN office here in Geneva by those two countries. To my left, she is the permanent German representative to the United Nations office at Geneva. Please welcome Ambassador Katharina Stach. And to my right, of course, representing the G20 presidency this year, he's the permanent Indonesian representative to the UN office here in Geneva, Ambassador Febrian Rudyat, ladies and gentlemen. Ambassador Stach, let's get right to it. Let's reflect back. Can you reflect a bit on the last few months of your G7 presidency, being halfway through it? What are some of the successes and findings that you have gathered throughout this presidency?
Good morning, everybody, and thanks a lot for the invitation and the possibility to talk about our G7 presidency. And you do know that many things have changed in Germany. The Chancellor is no longer a woman. It's Olaf Scholz. But I can assure you, global health and health has stayed a priority of our and the entire government. And this is also true for our G7 presidency. Global health is one of the top priorities. Now, in January, I remember quite well, I went back home to see senior officials, vice ministers, ministers in various ministries, also in the Chancellery, and they had prepared wonderful papers, such nice papers, and a lot of ambition. And now looking back after, and you mentioned being half through, I must say I'm quite proud what we achieved, and concrete actions have followed nice words. Now, what were the aims? The aims certainly were to combat the current pandemic, to be prepared for future pandemics, and not to forget the other challenges we are facing in the global health world. And the instruments were also clearly set out. What do we need to do that? We need clear and sustainable structures. We need funds. And also, and this is very important here for all of us in Geneva, we do need equity and international solidarity. Now, where do we stand? First, when it comes to the structures, I do believe we've come a long way. Now, first of all, the heads of states, they committed themselves to a strong WHO. And, this has not always been a given. And we already achieved, I think, considerable progress in this regard, also here in Geneva under German leadership, when we managed to have an agreement on raising the assessed contributions to WHO. And the heads of state of the G7 very clearly endorsed the recommendations, and they stand firmly behind that. Secondly, they also endorsed the endeavor of the new pandemic instrument, which we are engaging a lot here in Geneva with all the colleagues. And last but not least, reforming the AHR, and that is in a good way, I believe, as well. Now that's about structures. And of course, everything is intertwined. So let's talk about international solidarity and equity. And this is important for both combating the current pandemic, but also being prepared for future challenges, for future pandemics. Now, first thing is, of course, first priority was to get the vaccines to the areas where they are needed. And we have the Act A, and the G7 vowed and will support the Act A. And I was actually, when I read the figure, I was quite impressed, and I wrote it down. And I think it's almost 19 billion raised by the G7 to actually foster the Act A, and that's a remarkable sum. Now, of course, we've seen that having the vaccines is probably not enough. We also make sure that the vaccines turn into real vaccinations. So we have this initiative of walking the last mile. And there also, I think we put almost 9 billion into that initiative. And that is already, I think, a very great achievement. And we are working very closely together with you, and also bilaterally and multilaterally in this respect. Now, this was about vaccines. Not to forget, we did reach an important agreement on the TRIPS. That was also a big contribution in that respect, I think, from members of the G7. And what I find most important, we are actually making sure that the vaccines are produced in the areas where they are needed. So we have that project together with BioNTech, and the G7 heavily supported to actually build producing facilities in a couple of countries, for instance, in South Africa. And I mean, the famous saying about the recipe and the cook. So it's not enough to have the recipe. It's not enough to have the ingredients. You also need to know how to cook. And I was told that cooking the vaccines is quite difficult. So very concrete action. And I'm really proud that we've come that far. Many more things to say. Maybe I have another opportunity.
Absolutely, you will. Thank you so much, Ambassador Stasch, for this quick overview of the accomplishments during the G7 presidency of Germany. Now, let me turn to the representative of Indonesia to the UN here in Geneva. Much has been, we've talked a lot about the upcoming T20 conference, of course, that is going to take place right after this conference. Many of the people here in this room will be in attendance in Bali, but perhaps you can walk us through some of the accomplishments of your G20 presidency up until now.
Well, okay, it's working. Okay, thank you, Ali, for having me. And of course, it's quite a I'm very glad that I'll be able to join the old colleague inside the room in this gathering. Let me first saying by expressing the commitment of the government of Indonesia that the G20 should be an action-oriented and provide concrete solution and deliverables, and not creating a new problem. So it has to become a problem solver rather than a problem initiator. So that's why our presidency focuses more on priorities that hopefully will assist the world in recovering stronger. As the Indonesian Minister of Health yesterday in this remark mentioning that the strengthening global health architecture is a key priority. Of course, we need a strong global and multilateral efforts to ensure an equal global community resilience.
Is the microphone working? Take mine.
Thank you. Thank you. And of course, there's a need as well to harmonize a global health protocol standard to ensure less disruption to travel and economic activities. We also need to expand global manufacture hubs to LMICs, and as well as enhancing their capacity for pandemic prevention, preparedness, as well as response. One major breakthrough, if I may say, that has been mentioned several times yesterday is the establishment of the Financial Intermediary Fund, which is FIF. And I think FIF is can be seen as a starting point to support global effort in strengthening prevention, preparedness, and response to the pandemic. We also like to thank the donor, both G20 and non-G20 countries and non-state actors who have pledged funds on this particular FIF. The contribution partner of all partners has this demonstrated that under our presidency, G20 can also create ownership of countries outside the G20. So it's not only belong exclusively for the G20, especially on the issues of common concern. We will work collectively with to meet all the target so that we can ensure G20 can benefit of all. If one thing that I can say is very important during our presidency is about the partnership. So partnership, we believe, is a key element for our G20 presidency. We undertaken several consultations with civil society, international organization, as well as other partners to gather input and perspective from wide-ranging of actors. So I think it's not very inclusive. It's only the country which has the capability, economically capability, and considered as the biggest 20, the 20 biggest economic power in the world, but also including some of the country outside the G20 if they can contribute something. Of course, producing concrete deliverable is one of our priorities, and we encourage other members to contribute through tangible, also impactful concrete project. So far, for your information, Ali, we have received more than 600 concrete project proposal. So it's quite a number, both from G20 and bilateral mechanism, and we have curated to filter those which are more impactful. So we're going to use it or consider it as the G20 deliverable concretes. So these various concrete project will be finalized in the third Sherpa meeting in Yogyakarta. That will be at the end of this September. Everybody, I believe, will be there. And they will then be approved at the leader levels at the G20 at Bali Summit. So this is the thing. And in terms of geographical political strategies, I would say that this gathering of all G20 foreign ministers a couple months ago, amidst the war in Ukraine, is already a success. So for it, the first time, all the foreign ministers, even from the conflicting countries, they sat in one room and discussed two main issues. First, the importance of strengthening multilateralism, and second, the food energy crisis. I think it's quite an achievement for us. And of course, agreement and establish the financial intermediate fund, the fund with strengthening for emergency preparedness and respond to pandemic in the future is one of its crown result. You know, we so far the commitment has reached 1.4 billion US dollars. So I think this is the thing that I would like to share with all of the colleagues in the room.
Thank you so much indeed, Ambassador. Very impressive numbers that you have put forth there. Quite a number of achievements, and it seems to me, listening to the both of you, Ambassador Stash, that the aims they overlap many times. The aims, the ambitions. The question I have is how much convergence is there actually between the G7 and the G20 presidency? Is there some collaboration, coordinated collaboration between the two presidencies?
Yes, excellent question. Very easy answer. There's close collaboration. And when my colleague was speaking, I thought, okay, this could have been my speech. And indeed, maybe one good example is the fifth. You mentioned it. And we were working super closely together in this respect. And G20 was extremely important for us. And we really wanted to make sure that what was created there with the fifth was really, well, also the G20, but more than the G20 had ownership in that respect. And maybe to mention one thing very concretely, together we worked in order to ensure a strong role of WHO in the fifth. And I think we're on a good path there. And also, next step will be to think about projects that might be financed out of that fifth. And I'm quite happy. And I learned that many scientists are here today, or maybe yesterday also. And our health minister, Karl Lauterbach, he's very close to science. He's a professor of science of health himself. And he, together with other scientists, developed a project which could be funded by the fifth. And he says, okay, in order to be prepared for future pandemics, we need the expertise. We need future generations of scientists, of public health people, and we need to educate them. And that's why he will suggest to have hubs in a couple of countries where we can actually educate the future managers of pandemics. So I think that's very great. And maybe give me the opportunity because I said, one of the priorities of our presidency is also not to forget the other challenges in our health system. And just to very briefly mention, because I talked to a couple of people of you just before coming in here. Of course, the AMR is super important for us, also combating and continue to combat polio. And we will have a pledging event in October in that respect. The One Health aspect is very important, and we will continue to work there and highlight it. As well as, of course, the Global Fund, and we will try to make the replenishment a success. And last but not least, what I find a very important topic is climate and health. And I think we really need to put resources and a lot of thought in that huge area of challenges which is waiting for us.
It certainly has to or ought to rank very high on the agenda as far as priorities are concerned. Ambassador Rajat, let me also get your quick take on the convergence about the collaboration between the G20 presidency and the G7 presidency.
I think Ambassador Stas has already made a very eloquent explanation on that, but I just would like to add some more. That yes, I believe there has been several discussion and effort to align, to collaborate toward the common goals of these two entities. For us, an open and inclusive communication is a key. And of course, at the head of state level, for example, our president was invited to the G7 summit to discuss our G20 priorities. That is an effort to at least make a point of convergence, create a point of convergence for both gathering. At the Geneva base level, we also conducted joint briefing me with Ambassador Stas, G20, G7 priorities to the Geneva based ambassador. All the G7 countries, in fact, are members of G20, and I think it's only natural that priorities should also be mutually supportive. A convergence in the future is not impossible. However, I think we also must remember that G20 also consists of developing countries. This will naturally widen the scope of G20 priorities.
Thank you so much, ambassadors. Before I let you go, yesterday we started a tradition that we end all sessions by asking our speakers for a specific concrete recommendation that you would have for the many stakeholders here in this room and beyond. The question goes to the both of you, perhaps this time in reverse order. Ambassador Rajat, what will be your concrete recommendation to G20 leaders? First, you're one of them now, and to the stakeholders in this room.
I think the important thing is to maintain the open communication among all parties, not only state, but also non-state actors, and having forums such as H20 facilitate better change of ideas to tackle global challenges, and all bring different perspectives, and through strong collaboration with other forum, a better understanding, I believe, will be achieved, which can result in concrete solution.
Thank you so much, Ambassador Stas.
Well, never give up. And believe in multilateralism, because these challenges we can only combat together. And yes, it's cumbersome sometimes, but it's absolutely worth it.
Ambassador Stas and Ambassador Rajat, it's wonderful. It was wonderful to have both the presidency's representatives here in Geneva with us to give an insight into what their presidencies look like, and more importantly, what accomplishments they can deliver. Ambassador Stas and Ambassador Rajat, this is your applause. Thank you so much.
Thank you so much. Thank you.
You can leave the microphones right here. Thank you so much, because I'm staying in the middle and I'm going to ask my next two speakers. One of them actually is joining us virtually here to join me. She is, and I see, I'll wait for her to make the rounds and perhaps introduce the person whom I'm already seeing virtually joining us. He is the Secretary General of the Commonwealth Parliamentary Association. Stephen Twigg is with us. Stephen, thank you for joining us and making her way to me in the round. Somebody who is part of our host here. She's the chief scientist at the WHO, Soumya Swaminathan. Lovely to have you. A round of applause to both of them. Thank you so much. Great to have you with us. Let me start with you, Soumya. The pandemic, and we spoke about it numerous times yesterday, highlighted the gap between the science and policies. How, in your opinion, could we best advance and use the technological disruptions and innovation coming out of this pandemic to our advantage?
Thank you very much. Thank you so much. And it's wonderful to be with you all. I think one thing that we've learned during the pandemic is that science can find solutions for us, and it was unprecedented, the speed at which we learned things about the virus and also developed vaccines, diagnostics, and therapeutics. So I think all previous records were broken. The issue is, how do you make sure that the scientific and technological advances we have available to us, the tools that we have today, actually serve everyone around the world? And I think the word equity is being mentioned repeatedly, but I think we need to keep emphasizing that. So I think going forwards, I have a couple of concrete areas or examples I can give where I think that the G20 could play a role, but there are many other countries. Of course, all countries are important. The first is the new technologies. I mean, I think we've heard a lot about the mRNA and what it can do. I mean, the kind of vaccines that were created. So that opens up a lot of potential for use, not just for vaccines and for infectious diseases, but also for other diseases like cancer, and potentially also for animal health. But what we need is a democratization of knowledge and the sharing of know-how, and that did not happen in the pandemic. The technology was controlled by a few companies. So this is why we set up the mRNA Technology Transfer Program. And we now have, and I'm very happy to see Petro Terblanche here from Afrigen. She's the head of Afrigen, which is our mRNA hub in Cape Town. But we also have 15 other countries, including many of the G20 countries, that the LMIC countries, it's focused on LMICs, where we now have vibrant R&D. We're setting up this network. I'm very confident that in the next couple of years, we'll have many more health products coming out of this whole program. But again, there's a lot of thought to be placed on financial sustainability. How are we going to keep these operations going, and also how are we going to make these affordable and accessible to people? So this is just one example of technology, but obviously we have genomic technologies today that are not only helping us with surveillance, and we saw at the beginning in Africa, there were exactly 2 labs that could do PCRs. But today, most countries have either their own or they're relying on their neighbors to help them. So genomic technologies can help not just for pathogen surveillance, but for human disease identification and treatment of cancers, for example, and also gene editing now that can actually cure inherited diseases. Right now, again, these are very costly, very unaffordable, and available only to few people. So again, I think it's the technology sharing, the hubs, ambassadors, both of them spoke previously about setting up these hubs to train people. I think that has to extend to these new technologies. And I think the second area is really the dialogue between scientists, policymakers, and civil society communities, society in general. There's been a lot of misunderstanding also, and a lot of misinformation being promoted. And so I think we need to build those mechanisms where science is seen as a force that can be used for good.
Science that can be used as a force for good. Stephen, let me turn to you, and thank you for joining us virtually. Picking up on what Sumya was saying about the many technological innovations that came out of this pandemic, how do we keep this momentum going, and how do we make it more accessible?
Well, thanks very much indeed, Ali, and it's good to join you, albeit virtually. I wish I was there with you in Geneva. And I want really to pick up where Samia left off, because the theme for this session is the gap between science and policy. I think it speaks to a wider debate around the role of evidence and data in policy making. And the third element of the triangle is citizens and civil society. And I think at the heart of this is the question of trust, and who is trusted, what is trusted, and how we can rebuild and sustain levels of trust. We know that there is a much broader and deeper issue here about declining levels of trust in traditional institutions. It varies between different countries and societies, but it is a universal challenge. Some of this is a good thing. Some of this is about a decline in deference and people being willing to question and challenge things that maybe they didn't question and challenge in the past. But some of it is also, as has been said, about misinformation and so forth that we see. Talking about trust, as a former parliamentarian and Secretary General of the Commonwealth Parliamentary Association, politicians are obviously not always the most trusted people. I looked at the most recent research I could find into whom the most trusted professions are, and scientists came out on top, followed closely by doctors, obviously relevant to our discussion today, and politicians were right down at the bottom. But I think one of my reflections from looking at the COVID experience, but also looking at other health crises like Ebola, is often what can be done at a local level can be the most effective. There's long-standing evidence in the United Kingdom, and I think elsewhere, that often local members of parliament are much more trusted than politicians in general. So there's a relevance there to policymakers. We know from the COVID experience, but in particular from the Ebola experience in West Africa, the difference that effective community leadership made at the local level, trusted voices in local communities, perhaps being able to get over messages that voices from outside those communities might not be able to address. And then finally on this, there are some huge lessons that we need to draw from this experience over the last 3 years, absolutely echoing what has been said about the importance of expertise, but also of democratizing the knowledge, to borrow that brilliant phrase. I think there's a huge question for policymakers about how they keep up to date with technological and scientific advances. Science and technology move forward so rapidly, and politicians and other policymakers aren't always fully equipped to deal with those challenges. And at the heart of this is the relationships that are built and the effectiveness of communication. I'll leave it there, but hopefully I'll bring in some other points if you've got further questions. Thank you.
Absolutely. I'm going to come back to you in just a moment as we are speaking about the gap between science and policy in a post-pandemic recovery. Soumya, it seems to me that both of you are advocating for a greater role of science in decision-making in global health. Global health and policymakers would certainly benefit from that. This is what I'm hearing. So how do you make the science and evidence more appealing to policymakers, not just in the G20, but beyond as well?
Yeah, from my own experience, as a medical researcher and then also being a policymaker and working with a lot of policymakers, I think it has to be a dialogue that begins. And sometimes we're in our own silos. We do our work as scientists. We think that we've got the results and now others should act on those results. And we're not often thinking about the context in which such decisions are made. So I think a few countries have done well, but the majority did not really have any existing mechanism to bring the data, the emerging evidence, and of course it was changing all the time in a pandemic, but also then have the expertise from economists, from jurisprudence, from ethicists, from civil society, from behavioral scientists. And I always like to emphasize when we talk about science, it's not just people in white coats. Behavioral and social sciences are very important and are often neglected in our countries when it comes to decision making. And they are the ones who can bring insights as to what policies may work and which will not work, because they understand community behavior. So I think we need to now build those mechanisms. They don't exist in the majority of countries, so that decisions that affect people in general, whether it's related to taxing, health products or harmful products like alcohol and tobacco, or work on air pollution, where it has to be an all of government and all of society approach. So when there are these big threats to us, whether it's climate change or air pollution, or it's a new infectious disease threat or an existing infectious disease threat, and you need behavior change at the individual level, the community level, I think we need a different way. And Stephen was, I think, referring to these engagements that we didn't do during the pandemic. And I think this is why we built these walls and trust kind of broke down, because we were talking to each other. We weren't talking with each other. So I think we need to build that. And I think strengthening institutions and countries is very important. I think we heard from the ambassadors about training people who can respond to pandemics. Clearly, investment in science, especially in young people today, there's huge amount of interest, I think. So we should leverage that young people do want to make careers in science, we need to open up opportunities globally for them. And so institutional mechanisms are important. Regulatory, we've seen the need for regulatory. And the last thing I would say is when we talk about new technologies, there are always ethical considerations, because every new technology comes with huge amounts of potential benefits, but also some risks. And again, we need to be very cognizant. And the WHO in the last 2 years has come out with guidance, both for genome editing and also for the use of artificial intelligence in health.
Thank you for that, Stephen. Let me throw it right back at you. We scientists are focused on the results, as Sumya, and maybe sometimes not so much on the context in which those results will be placed. As somebody who sort of has been walking between science and policy in those two worlds, and you're familiar with both, how do we bring the two closer together? Trust is one aspect you've already mentioned. What are some others?
Yeah, and I think my first observation on this is that democratic politics often struggles to address long-term issues, that the electoral cycle can dominate. And when it comes to big challenges like future pandemics, climate change, those sorts of things, democratic politics is not always very effective at addressing those questions. And I think part of this is about how the policy world and the political world operate. The more that a cross-party consensus can be constructed on these sorts of questions to look at these future issues together, that's not always as easy as it sounds. It often isn't, but is incredibly important. But also, as has been said, the work then with the scientists and crucially with citizens. So I think politicians and parliaments have a really important role in trying to forge consensus where it can exist, to identify dilemmas and trade-offs and conflicts, and then to engage scientists, other experts, and crucially citizens and civil society. And I think for the scientists, if I may, I think sometimes it is about acknowledging that there will be different perspectives within science. There were different scientists had different views about the sort of appropriate policy response to COVID, and that's inevitable, that's right, that's healthy, but having a culture in public discourse where those sorts of differences can be considered and acknowledged. If I might make two other points on this. One is about the importance of education. One of the things that strikes me, having been a parliamentarian, is how few scientists go into politics. There would be very few, even doctors, but people who are sort of more academic scientists, social scientists, maybe a little bit more. And I think there's something to be thought about, particularly for higher education, but perhaps also for earlier phases of education, about how public policy elements can be better built into science curricula, but also for those that are studying, as so many of us who go into politics do, studying things like politics and economics, having those elements of the scientific dimension to public policy being part of that. And that then hopefully, at least to some extent, we can break down those silos that result in policymakers not always being confident. And I'd say politicians in particular not always being confident about some of the big challenges that we've heard about, whether it's artificial intelligence, oversight of rapidly changing technologies. And then the final point, I think, is about framing. And in particular, looking in the context of public health, how we frame these issues, I think is critically important for citizen engagement and support for measures that may be needed in the future. And a lot of this, I think, is breaking down some of the traditional silos. So I think, we're talking about health. I think the point was rightly made earlier about the relationship between health and climate change. I would say, in a sense, there's a triangle of health, climate change, and education, where if you can break down the silos between those three worlds, we may be much more effective in addressing all of the challenges covered in those three themes.
Thank you so much, Stephen. I heard a plea to scientists, not just in this room, but beyond, to get into politics. That's what I heard. But Sumya, to wrap up, and as we always do, of course, is the one final and concrete recommendation that you have to our many stakeholders and leaders in this room.
Well, I think that leaders need to invest in health. And as Dr. Tedros often says, we go into these cycles of panic and neglect. Now that many countries, are in a much better state in terms of the pandemic, there will be a tendency to just try and forget about it and get back, to business as usual. So I would say that investing in health doesn't mean just building more hospitals and health centers, but it's really, I think, focusing on the upstream determinants of health, because it is actually, most people don't know that how healthy you are. Only 20% of that comes from your health care, and 80% is actually upstream. It's where you live, what you eat, the air you breathe, etc., water, sanitation, nutrition, and air. And I think that's where things are not going well in most countries. We're going from bad to worse. And so and that means a multi-sectoral. It's not going to be the health ministries or departments. Action has to be taken across in other areas. And I think we've seen now cardiovascular diseases, mental health problems, all of these are going up, partly because of underlying factors, but also because the added stress of the pandemic. So I think we have to think about those factors. Every country needs to do an analysis of where they did well and where they're not doing well, and really go and invest. These are invisible investments, unfortunately. It's not a big building or a bridge that somebody can inaugurate. But ultimately, if you have an unhealthy population, the economy is not going to do well.
And we're going to take a deeper dive into those diseases that you've just mentioned, some of them, and the staggering numbers of death they produce annually on a global scale. Thank you so much for that, Soumya. Stephen, to wrap up, also, let me get you a final recommendation to this distinguished audience.
I think there's a lot of consensus in this discussion. I think it's about recognizing the linkages. Health systems can do so much. We do need investment in health. We do need universal health coverage, but actually the linkages to addressing poverty and inequality, poor education, issues around climate change, absolutely vital. And of course, we have the United Nations Agenda 2030, the Sustainable Development Goals, which are a bold and ambitious attempt to bring those things together. So I guess my recommendation would be to align what comes through G20 with what's in the Sustainable Development Goals. And as part of that, recognize that in the challenge around COVID and the resource that's gone into that, we mustn't forget about all of these other specific diseases like malaria, AIDS and HIV, polio, TB, cervical cancer, neglected tropical diseases. So let's have some focus on those specifics again, but also locate this in the broader challenge of achieving a more sustainable world that is fairer. And I can see no better way of encapsulating that than the UN's Agenda 2030 and the Sustainable Development Goals.
And to accomplish all that, it's quite clear from this conversation that the gap between science and policy has to be overcome and has to be narrowed as soon as possible. That was the Secretary General of the Commonwealth Parliamentary Association, Stephen Twigg, and of course, the Chief Scientist here at the WHO, Soumya Swaminathan. This is your applause. Thank you so much.
Thank you.
And now, as you can see, we are off to a very dynamic start of day 2. And our first panel will be no exception, because I'm delighted to hand over for an extremely important and timely discussion on digital and health to Rajendra Pratap Gupta, who's extremely familiar to many of you. He's one of the thought leaders when it comes to digital and health. He's the chairman of the Dynamic Coalition on Digital Health and the Internet Governance Forum. Rajendra, great to have you with us. Take it away.
Thanks, Ali. Good morning to everyone. First, I'll call my colleague Alan Labrick, to deliver his keynote.
I don't know if this is live. There we go. Thank you, Dr. Gupta, and distinguished guests. Good morning. It's a real honor to be speaking to you today as part of this critical H20 meeting at a really important time when we're reflecting on the lessons learned from the COVID-19 pandemic and mapping a path forward for a stronger, more collaborative, and resilient global health system. As Dr. Tedros and others stated in their remarks yesterday, We believe that digital is today intractable from the practice of effective public health and clinical medicine. The appropriate use of technologies will help WHO member states achieve the triple billion targets in this instantly connected world. Over the last decade, the World Health Organization has been a leading influence in examining the emerging space of digital health, distilling evidence, building consensus around a shared vocabulary, and establishing pathways to the institutionalization and sustainability of digital health investments at a national scale. These being just a few guides developed to strengthen global health systems architecture. But bringing together the many voices and perspectives in this complex multidisciplinary ecosystem spanning medicine, technology, informatics, and primary healthcare, to name just a few, a working definition has been widely adopted to help ensure consistency in policy and practice around digital health, which you see here on the slide. Beginning in 2005, the first World Health Assembly resolution on e-health and subsequent resolutions in 2013 and 2018, the call for support and need for collective action was clearly heard by WHO. The 2020-2025 Global Strategy on Digital Health has helped to define a common transformational agenda of principles and clear objectives for stakeholders to work together on towards achieving the triple billion targets and health SDGs through, again, the appropriate use of digital health solutions. First, there are 4 guiding principles that identify important foundational investments needed for lasting digital health infrastructure. These range from national commitments enshrined in digital health strategies and policies at a national level, to the building of a resilient and adaptive digital infrastructure, which allows care providers to share information safely and better track health system performance by committing to interoperability. The strategy also lays out 4 important objectives for focal activities to prevent wheel reinvention by encouraging collaboration and sharing global goods, to ensure investment in digital health strategies as part of national health sector plans, and to support the development of legislation and policies which promote good practice, which protect individual health data, and most importantly, advocate for systems which place the person at the center, addressing issues of equity, access, and affordability in the face of challenges which require innovation for a response. Now, reflecting just briefly on the pandemic's lessons for digital health, there are a few important ones that should be discussed and learned from. These include, at a high level, again, due to time constraints this morning, the importance of strong governance, legislation, standards, and interoperability frameworks. We must build strong multi-sectoral collaborations, such as public-private partnerships, which can be responsive to future system shocks. Investments in digital literacy, as we were just discussing a moment ago, will be needed to ensure that health systems are able to deploy and dynamically adapt digital systems in an emergency. But last but not least, trust. And this is a word we've heard over and over these last 2 days. Trust is at the center of success in digital health, at the individual, national, and regional levels, so that citizens have faith that their health data is secured and protected, that the provenance of health information, such as test results or vaccines, is verifiable, and that individuals can move freely within their countries, within their communities, and across borders with virtual credentials attesting to their health state. Digital health interventions are powerful tools for health system strengthening and universal health coverage, as we have seen. But we have also learned that there is a wide array of experiences that we need to learn from in these last couple of years. It's up to us to learn from these experiences and forge a path forward, built on collaboration, built on trust, and built on preparedness. The next global challenge, as Bruce Aylward pointed out yesterday, may be just around the corner. Thank you.
Thanks, Elaine, for the wonderful, insightful presentation. As chair of the panel, it's my duty to put my comments at the start of the panel. So firstly, I thank great friend Alan Donnelly for his wonderful initiative of H20 and the Health and Development Partnership and hosting this impactful forum here. I also thank Dr. Tedros and the WHO for the commitment and support to this. And if you reflect back on COVID, we will see, that it has shaken the world. And when a shakeup happens, leaders emerge. So as they say, that we shouldn't let a good crisis go to waste. So now we had the loss, we have the lessons, we should reflect back, learn, implement, take action. In fact, COVID-19 is probably the worst documented crisis in human history since we started documenting. And before COVID, digital health was only hype for most quarters. And during COVID, it was the only hope because the world had come to a stop. Doctors won't meet the patients, patients won't be able to meet doctors face to face. So just imagine what would be the world without digital health if it was not around. I think very clearly COVID has brought to the front the importance of health, importance of science, private-public partnerships, policies, regulations, and vaccine development is a testimony to this. It was done in record time. I think the learning is without health, there would be no humanity, and without humanity, there will be no health. That's a clear message. COVID-19, I would call it chronic COVID because it's going to have a lingering impact on those who had, and it's going to stay. And now monkeypox. So it's like a decade of the virus. It's also a decade for reglobalization in terms of science, partnerships, philanthropy, and action. We need to transform healthcare through digital health for all, with all, by 2028, when it is 50 years of Alma Ata. We promised health for all by 2000, we're still not there. At least we can promise digital health for all. So it's not going to be easy. If you really look at how medicine has evolved, what drove medicine in 18th century was biology, 19th century chemistry, 20th century physics, and 21st century is maths, is data. It's not going to be an easy transition. I think as Soumya put it very rightly, it is beyond white coats. So I think there'll be bigger issues for us to address. It's not the change that should worry us, it's the speed of change that's happening that should worry us. I think we have to address the issue of trust, equity, data as a global good, innovative financing, and to address and to leverage the full potential of digital health. I have probably the world's most impactful leaders with me on this panel. It is very difficult to get into detailed description of what these people have accomplished, but if I were to put in one line, these are the global doers and thinkers and influencers in health. And with this, I pass my first question to Omar Najim. How will digital health help in preparedness for the pandemics?
Sure. Thank you very much for the opportunity. So I come from a place called Abu Dhabi, I hope you know. So it's the capital of United Arab Emirates. If I take a step back and you look at the global health challenge that we are facing today across the world. So there are 50% of the population of Earth do not have adequate access, or they have limited access to healthcare. The amount that we spend on healthcare has been growing by 4% over the last 10 years, to the tune of $8 trillion today. And also we continue to face workforce issues. The workforce in healthcare is highly competitive. It's a well sought after talent. It's being faced in well advanced countries as well as challenged countries. To identify where do we get the next workforce, not only in the sense of their healthcare skills and experience, but also in the sense of having skills that are fit for the future. It's a continuously changing element. Now we look at Abu Dhabi specifically, we more or less been facing the same challenges, which is the sustainability of the cost of the healthcare, the accessibility to high quality patient care, and how do we get the workforce up to the challenges of the future. It's a changing world. What we did is about 4 or 5 years ago, we started on the digital health journey. We already have EMRs in place in many of the hospitals that exist there. We already have the clinics equipped with localized digital health capabilities. And we started on a journey to connect everybody. So as of today, 100% of every single clinic, hospital, pharmacy, or healthcare provider or prevention element is being connected to our health information exchange. We call it the MULTILATERALISM. Now it's a prime investment that we took on, and took on, we feel, successfully. It's one of the, I think that the limited number of ecosystems globally to have that. But it came to the fore, and I can categorically say it was one of the main elements for a successful COVID-19 response. I think with the different ranking, it identified Abu Dhabi as one of the best cities in response. So we continue to have one of the lowest mortality rate globally in COVID-19, about 0.2%. We continue to have a true flattening of the curve in terms of infection rate, and all of that got achieved with a 0 day of full lockdown. So over the last 3 days, people continue. Of course, we encourage them to stay at home. Where digital health came in, the health information exchange, it allowed us to generate the data to be transformed into insights for decision making, enabling the decisions to be executed very fast, enabling the information to be shared very fast. Dynamic situation as COVID that we faced globally needed that element of response and sharing of information. The digital health has allowed us to do that. It allowed us to protect the most vulnerable in society. What we did is we identified a cohorts of the population we serve, i.e. the one who are above 50 and the one with more than 2 chronic diseases, and have targeted, segmented intervention for them. More educations for them, more testing for them, more services to allow them to adhere to the advice of staying at home when the pandemic is going through a wave. And when the vaccination became available, they were first in line to do that. And when the therapeutic became available, it allowed us to, just to give you an example, when somebody out of that cohorts of population get tested positive today, second day, they go into the list where they get called and say, you've tested positive yesterday. We need to come and provide the treatment for you, being it the sotrovimab or any of the other medications, but as well as to monitor you closely. If they can't, a team will be deployed to them to protect them and protect their family. So that is the impact of that. But with the dashboards, it allowed us to generate about 300 dashboards available for the different layers of the response, from the Gold Command, from the fields, from the field hospitals, all the way to the prevention team that exists in neighborhoods and community. We think that digital health is here to continue. And we feel that going forward, that system needs to be built on. What we are doing so today, it doesn't matter where a patient goes to seek help. If it is a smaller clinic in the middle of the desert at the border with Saudi, or going to Cleveland Clinic or Mayo Clinic, large hospitals in Abu Dhabi, all of these information got logged into the health information exchange that get into what we call a single patient index. That single patient index allows us to do different applications, including population health, including registries, including prevention initiatives. And now what we also doing is we have the largest existing program for full sequence genome. So as of date, we fully sequenced 270,000 individuals, and all of these genomes will go into that system. What you have now is the phenotype data, the clinical data, and the genotype data. All of that will be becoming available to do more in improving the health for the population, not only in providing healthcare, but also in designing preventative measures. Going forward, we think there are more information that will be going around the world, and the ideas around the social media data, the wearable data, all creating what we call the digital twin. And then all of that at the policy level will be combined. This is the healthcare lake. It will go into a data ocean where you've got data from environment, from traffic, from healthcare, from education, all in one place, allowing the entrepreneurs, allowing the different initiatives, the policymakers at the national and international level to develop solutions that will prevent this. Solutions are already there, and it's proving its worth in the digital world. So the telemedicine, we talked about the workforce. There are signs of digital improving the productivity between 10 to 40%. There are signs that digital, if implemented fully, will reduce healthcare spend by about 20%. It will be improving outcome in different areas. Many solutions exist around the world, and it's all showing the right way to do it. So I think, in a sense, what we can see and where we're going requires digital health not as a nice to have, but as a must to have. Otherwise, healthcare is not sustainable at local or global level. Otherwise, the quality continue to be patchy and fragmented. Otherwise, we continue to have a workforce that is being trained and skilled to do things that might be not needed, or more importantly, might be harmful for the future needs of our patients. I'll stop there and I'll say the recommendation later on if I may. I think I've taken enough.
Thanks, Omar. And this is Omar Nakeem, Director, Executive Office, Affairs Office, Abu Dhabi, Department of Health. Now, he's made a very important point of connecting the people, the populations. Lakshmi, coming to you, for certain countries of an economic strata, it is maybe easy to comprehend that they can connect populations, invest. But what about LMICs? LMICs, if you look at the populations they have, they can either pull us out of pandemics or drag us in. Now, based on your experience, how would you think digital health helps them in preparedness for pandemics?
Sure, and thank you for the opportunity to be here and responding to that question. So I think the experience from LMICs has been fairly varied, right? But what we've seen is the use of digital health, at least at a national level, to identify outbreaks, to identify, but to do disease surveillance and identify the outbreaks, to be able to use digital health for things like contact tracing, and using that data to, at least at an aggregate level, identify which populations need to be targeted for further follow-up or for vaccines and things like that. What we saw in a number of countries, particularly those that had, as the speaker before me was mentioning, strong systems, digital systems before the pandemic, were the ones that were able to use these digital systems effectively, whether that was disease surveillance systems that were being used to respond to Ebola or track everything from malaria to cholera to so many other diseases that are tracked in countries anyways. Countries that had strong contact tracing systems in place already that were able to quickly modify and update those for COVID. Countries that had strong health management information systems and staff and health workers who were comfortable with digital technologies before the pandemic were the ones who were then able to use the digital technology and address the pandemic itself. So that's been a strong learning from LMICs, I'd say.
Lakshmi, in the context of LMICs, what's the role of global goods, given that there are limitations and there are competing priorities? I think my prior speaker also said, I think Soumya talked about also education in that. There are competing priorities. And when I come from a country where we know there are budget constraints, but we have the same huge populations to serve. So what's the role of global goods here?
Global goods have been invaluable, both during the pandemic, before that, and continue to be at this point, right? So for maybe the broader audience, global goods are essentially, in the context of technology, typically open source products that countries can use for their specific needs, configure, customize them, and extend on them for their own needs. You have, I think, 50, 60 plus countries at this point using the same core software for their health management information systems. You have, I think, 20 plus countries that use the same core software for their electronic medical records at this point. And a number of them, again, use these existing systems to quickly stand up COVID-19 systems that were relevant for COVID-19, right? Which meant, one, as you mentioned, that they didn't spend their own resources in developing their own systems, but also meant that they could very quickly respond because these systems were in place already. So absolutely, I think global goods from a technology perspective have been invaluable. And I would argue there are global goods like standards and best practices, interoperability standards particularly, that have been, again, valuable in countries being able to quickly stand these things up.
Thanks, Lakshmi. You made a very important point about, disease surveillance, contact tracing, the data that helped in vaccine. Now, putting to Anna from Google, we have been talking about data, and how do we use data for policy and decision making? Your insights based on experience and action points for public and private sector.
Yes, thank you for the question and the opportunity to be here. So my work with the pandemic is, with Google, we did a lot of work around COVID. We worked with a lot of different ministers of health, speaking to them how to build tools so they can make data-driven decisions. And we saw kind of two main failure points with that work. So one was on the kind of analysis side, there wasn't a lot of consultation early on. So governments had collected all this valuable data, but there were gaps. And these analytical tools, machine learning, artificial intelligence, they're not magic wands that can fill in replicates, controls, metadata gaps. And so as you're building out your data platforms, reach out to any of us in the kind of machine learning AI field, because there are ways to collect your data that could save you time and money and make it more effective. So that was kind of one key thing, is we can't fill in those holes as good as we try to be. And then the second thing was, in terms of on our side, our responsibility is we need to reach out to policymakers earlier as well. So it's on our behalf that we need to create that communication, because oftentimes we build tools that aren't able to connect into current workflows. We need to understand how current policy decisions are being made, so we can build effective tools that insert themselves instead of building you something that essentially can't be immediately used and utilized. So I think on both sides, we need to communicate early, communicate often. The way I think of it is, policymakers are like a Michelin chef, right? And my responsibility is to go to the grocery store and get you what you need. I should ask you what you're making before I, give you a head of garlic and some broccoli, right? So, so we need to and not just Google, by the way, all of us, right? Facebook, Amazon, Microsoft. I mean, Google is one of the biggest investors in health tech in this area. We've been doing it since 2008. We want to be at the table. We want to help. We have resources. We have information, and we've made a lot of mistakes. We've done a lot of things wrong. So when you're building your system, we can try to give you that information and lessons learned of what we did and how to bypass that, how to build a better system, how to do it with limited resources. So it's, I think on both sides, we need to communicate more, we need to communicate more often, and we need to build things that you are actually going to use. And the other part, the last part I would say is, in my experience with talking to different ministers of health over the course of the last 2.5 years, is that there was this, I don't know if I'd call it fear, but there was this kind of hands-off approach of wanting to understand, not wanting to understand, but maybe so overwhelmed with the information that's coming at them that the idea of artificial intelligence, machine learning is this black box. And in some ways, it is a black box, right? But if you know how to drive a car, You know where the accelerator pedal is, you know where the brake is, you know how to turn the lights on, you know how to open the window. They're the same kind of elements to artificial intelligence. There's regulations, there's checks and balances, there's ways to make aggressive models. And I would say I would encourage the policymakers to invest in that education as well. And we're here to help provide with that. But there are these kind of boundary conditions that are really essential, because machine learning, artificial intelligence, it's not going away. It's going to become even more important in decision-making properties. And we should be kind of working together on that. So thank you.
Thanks. And I have another question for you. Considering we had the Commonwealth Secretary of the Parliamentarians, and he said politicians are rated at the bottom in the trust. And when it comes to data, there's another issue of trust. And we're talking of Google, and how do we build trust, when it comes to data with policymakers? And I'm sorry for merging two questions, but the common word is trust.
No, I love it. I mean, the Secretary General Stephen said trust is one of the biggest issues, and I absolutely agree. On the technical side, those mechanisms are there, right? And we need to do better due diligence about being transparent, what they are, what's happening to your data, how your data is being used. That's on our side. I think it really comes down to, this kind of social, this emotional decision about your data, right? It's personal, you own it, you want to control what's happening to it. You should know what's going on. So I would say, governments need to think differently about what data is currently out there. We did a sentiment analysis piece on vaccine hesitancy across 50 different countries. The data that we got from governments, from surveys, traditionally acquired data, was only maybe 10%. Most of the data used for that work was publicly scraped data. We're talking about Twitter. We're talking about publicly available data on Facebook. There's a lot of data out there that can be used to understand what your community is saying. And they're making it available. They're speaking. They're giving you information now. And so there are tools you can build on this data to listen, to understand what people are saying. We don't have to collect data in the same traditional ways anymore. We need to think differently. So that's one thing. But when we're thinking differently, we need to also have a bottom-up approach. We need to talk to the communities about how they want to use this data, how it needs to be implemented. How do you build trust? You have a conversation, right? We move from these virtual meetings to in-person. Trust is sitting there face-to-face in the room, having that conversation. What do you want? What do you want us to build? How do you want your data to be used? That's how you build trust. And we need to do that, right? We need to be part of that conversation, and we need to be responsible for asking those questions. I would say another way is showing impact. So, Israel is a great example. Their government's taking a digital first strategy, and look what they've done. They've built an interconnected healthcare system. They had this vaccine distribution that was very aggressive early on. They made a huge impact. And so we need to take from those countries that are taking a digital first strategy and show the case studies to other countries of what is possible, what can be done. Here is the art of possible, and what would you like to do in this space? And the last thing I would say is we need to ask permission, right? When we take something from someone, there is that pullback, right? We need to open our hand and say, what do you want? What can we use? What would you like us to do? And I just think that ask permission approach is going to maybe open up some more channels that we didn't have before. So.
Thanks. And I may have a question, but we'll come back after we're done with others. So a very interesting point of trust and sharing. And this brings me to Giorgio Moretti, who has a unique experience of working in both finance and health. And he has long experience of doing disruptive things. Giorgio, when we have trust sharing, it comes to best practices. Without that, you cannot do that. So over to you, your vision and insights for action.
Thank you, Professor Good. Thank you for the invitation. Yes, I will try to be very practical in my speech because the pandemic has been a very, very important lesson for us in terms of one word, speed. Speed. The time to arrive to define the right things to do in the continuously changement of the pandemic situation has been a more complex situation that we must manage in the last time. If you remember the beginning of the history of the COVID-19, sometimes we read, we see incredible mechanisms to manage that complex condition where nobody knows what is the best practice to manage that specific condition. And in the world, there was, I don't know how many teams that worked to find the best solution to manage that specific patient in that specific condition. This is the history of the medicine. No? The problem is to apply the best practice for any type of disease. But in the pandemic situation where nothing we know, nobody knows what is the best way to manage the situation, the problem is speed. Speed for what? Speed to share the information. Speed to share the best practice. Speed to analyze what we call best practice, that many times we understood that it wasn't best practice. If you remember at the beginning, no ibuprofen, only paracetamol. After 16 months, no paracetamol, now ibuprofen. And there are a lot of examples of this type of no correct behavior to manage an incomprehensible new disease. What is the more important thing that we need to prepare ourselves, the world, for the new pandemic situation? We are in the house of the WHO, and I hope that WHO could be the right organization that can do the correct management of the best practices in real time. Real time is the issue. You talked before about the democratization of the information, of the knowledge. That's very important. But the point is, who will be the orchestrator of the democracy of the knowledge? That's a very important question. But an organization like WHO can have the power, capability, gravity to really collect, orchestrate the best practices that is ready in that specific moment. Another very important point is in which way we can distribute this information. The best practice is a complex contest. Best practice, it means to land in the practical activities. What is the information that we must collect in that specific condition? What is the information that they must present and analyze in that specific condition for that specific patient? What is the best diagnostic examination that they must use for that specific condition? And what is the best therapeutical activities for that specific condition, for that specific patient? This is the best practices. And then our company that we work in 40 countries, we have more than 500 million patients managed with our EMR mainly in Europe. We invest in the last 15 years an incredible amount of money to build an instruments to collect best practices, to distribute the best practices, to configure dynamically the EMR for that specific condition. And then that's the fundamental point to prepare ourselves for the next pandemic situation. An organization that have the credibility, the capability to collect the best practice, to transform paper in a usable object that automatically can reconfigure dynamically the EMR, the routinary instruments that any doctors and nurses use any day, in any moment to manage that specific patient. That's a big value. And another last part of this history is the possibility to collect in real time the feedback from that specific best practice. And all scientific institutions can analyze what has been the outcome of that specific best practice. And you can readapt in real time if the result of that best practice is not perfectly correct for that specific condition. I remember you that probably in the last 2 years, we have a minimum 20 different best practice. We saw changement in the best practices any week. Try to imagine to train the doctors in the routinary activities to remember what is the best practice for that specific situation. We are ready to do a donation also to the WHO. Years and years and millions of investment to prepare the world for the next pandemic. Vendors like us must be ready to adapt our EMR to receive automatically the best practices that arrive from the organization like WHO, to be ready immediately to manage correctly that specific situation with the best quality of the healthcare management that is possible to do in that specific moment. That's my contribution, to be very, very simple, very, very practical in the possibility to start from now to prepare ourselves for the next pandemic situation.
Thanks, Giorgio. Tamir is the head of partnerships and innovation at Meta. He's an epidemiologist. Tamir, we have heard connecting people, sharing best practices, the role of governments and global goods. And if you look at the pandemic and how we overcame it, in a record time, coming with vaccine, coming with passports, and the systems, they were done actually in weeks, not in months. This didn't happen without private-public partnerships. So what's the role of private-public partnerships of your experience in addressing the issue of pandemics and the overall healthcare strengthening of the systems?
Thank you, Dr. Gupta. So I'm Tamer Farag. I represent Meta Health. Meta used to be called Facebook. Meta is the company that owns Facebook, Instagram, WhatsApp, and Oculus VR technology. So it's a real privilege to be here. Thank you. So when the pandemic began, it was a time of great uncertainty. And we saw people turn to Facebook, Instagram, and WhatsApp for information, care, and support for their healthcare concerns. We saw this energy, this goodwill and demand, and then we grew our products and programs to respond. We worked with WHO, we worked with UNICEF and ministries of health and other partners from around the world to quickly meet this demand for accurate information through innovative uses of our technologies. And then by bringing together the expertise of the global health community with the reach of social media, our partners were able to meet the needs of their stakeholders at unprecedented scale. I'll give you just two examples. Governments, NGOs, and international organizations received over $100 million in ad credits from Meta. And we estimate that this led to more than 80 billion impressions of accurate and reliable information. Remember, this was at a time of utter chaos where people didn't know what they should know. And we were able to deliver this. UNICEF India worked with us to design an ad campaign that reached 98 million people and led to a 2.5 percentage point increase in people reporting that they thought the COVID-19 vaccine was effective. A randomized trial published recently in Nature Medicine found that a Facebook ad campaign led to a reduction in holiday travel and subsequent COVID-19 infections across the 10 million people who saw it. Another example, safe blood supplies are always hard to secure in the best of times, but it was potentially a disaster during the pandemic when people couldn't leave their homes. So in response, we accelerated our work with blood donation partners to increase access to our Facebook blood donations feature. That connected over 145 million people as potential blood donors in more than 40 countries. And we saw, in the case of the United States, Brazil, and some other countries, double-digit percentage point increases in the amount of blood that was being donated. So reflecting on the impact of digital health solutions, one way to encourage more partnership is to create more demand from global health partners by making digital health solutions a routine part of health strategies. People are online, and we ought to meet them where they are. Thank you, Dr. Gupta.
Thanks, Tamir. That's very interesting that, Big Tech actually made a big difference to us being prepared for finding the pandemic. This brings me to Bert Hartog, who's Senior Director at Clinical Innovation at Janssen which is Johnson & Johnson. So Bert, we have looked at all aspects. That brings me to the fundamental of digital health, human interoperability, skilling. You have doctors being skilled, but frontline health workers, probably not. This also brings me to the issue of, we talked about data transfer, best practices, so the cross-border transfer of data. And without these two, there is no health without digital, because you don't transfer data and you don't have skilled people. So over to you for your insights.
Thank you, Professor Gupta, and thank you for that nice introduction. In technology, there's a very well understood connection between people, process, and technology. You need all three in order to be successful. And the same is true for the global health architecture. We need people, process, and technology connected for effectiveness and for efficiency. We've heard about putting in place a robust infrastructure and technology frameworks to support global healthcare. We've heard some impressive examples from deployment of technology at country level in communities that really help change the way healthcare evolves and change for good the health of people involved in these communities, in these countries. We've heard some amazing innovations made possible by smart use of technology and very close partnerships between private and public sector in collaboration with the communities and countries around the world. But to make innovation last, we need people and process more than anything. So let me focus a little bit on people and process. For people, it was mentioned before, people need to be equipped to use technology. If people are not equipped to use technology as designed, they'll get frustrated. They won't be able to use the technology as designed, so the output will not be as expected. Healthcare workers and frontline workers in particular, the nurses and doctors who deliver care, they need to be comfortable using technology as designed. The idea is there, the principles is there, but the mechanism isn't always in place. Using systems based on a level of comfort will result in better data available for generating insights. This will require education on the ground and in the field. Fortunately, there is already a tried and tested framework for this type of education. The world I live in Janssen R&D, is where we do clinical development. And we have this framework that's called Good Documentation Practices. It was instigated by law, but it's now common practice across clinical development for manufacturing, for laboratory, and for clinical. Everybody is trained in these principles. It's very accessible. It's not rocket science. But if you don't know about it, you can only guess what's expected of you when you use these technology systems. So my first plea would be to look at that framework and see how it can be used to equip frontline workers with the practices to actually use these systems, document data the way it's supposed to be documented. Data is king, and healthcare thrives on data. We've heard many examples there. More data generally is seen as better starting point for generating insights. But data is not always a good thing. Bad data is a bad starting point for generating insights. So we need to look at the other side of the medal. Data one side, the other side of the medal is process. We need to be able to generate reliable insights faster to give us that line of sight on what's happening in the world that will allow us to be prepared for what's coming. That's really the connection. We've heard about it yesterday, we've heard about it today. Not all data can be found in one system. For example, and this became acutely visible during COVID, outcome data is often not captured in electronic medical records. It's captured in different systems, civil registry systems, national level registries. So interoperability is essential, I would say critical, for generating insights on the evolution of disease and the impact of disease, pandemic or not pandemic related. Interoperability and cross-border transfer of healthcare insights are critical as countries shape policy to govern and protect the health data of their citizens. The good news is that there is technology that allows privacy-preserving analytics. There's also knowledge to secure data, and in particular sensitive data sets. So let's make this part of the healthcare architecture. Let's use these technologies to make sure that trust on the data, on the transfer of the data, on the insights generated from the data is based on robust processes. Then we can really yield the fruits of these investments. With the right governance and policies in place, and people equipped to using technology as designed, we will be able to collect better and more consistent data to improve our line of sight on what's happening. But also, and I would like to connect back to the comments made at the very beginning of the morning, when people are more comfortable using technology, we will be able to continue attract people to join healthcare, to want to work in healthcare. And not only that, we will also be able to reduce the frustration with the people in healthcare today who don't always know how to make use of systems. We will be able to keep them and allow them to stay in healthcare longer, which I think is, the comment was made this morning about politicians and scientists and attract scientists to politics. I think with equipped people to use technology, we can continue to attract people to healthcare and keep the people we've got in healthcare. So let me close there. I hope this sheds some light on the people and process side of technology.
Thanks, Bert. Excellent insight. So the last two things left for this very important panel. One is to get key takeaways from each our expert panelists, because as you know that this forum is about feeding in the G20 leaders, the finance ministers and health ministers on ideas for action. So I'm going to request each one of you for your key takeaways and then open the floor for questions. So first, Lakshmi, what are the takeaways that you would give as insights for action for the G20 leadership?
Sure. So from an LMIC perspective, I think as I was mentioning and several speakers mentioned, I think the need is not just for investments in pandemic preparedness necessarily, but thinking about health system strengthening in general, particularly for cross-cutting digital health investments, right? So not thinking about specific diseases or specific areas like pandemics, but how do we improve infrastructure, policies and regulations, digital skills and interoperability as a strong foundation that can then essentially help us address crises as they come up.
Anna?
Yes, thank you. I would say yesterday's conversation really focused on a financial discussion, and there are a lot of resources beyond just cold, hard cash. And I would say, call us, because we have some of these resources and we want to share some of these resources. And I don't just mean Google, I mean Meta, Microsoft, Google, Amazon. We're working in this digital healthcare space and we don't have your number. So we need you to call us, right? And we want to help respond. And we have these additional resources, this education, this training, these mistakes made, lessons learned that we want to share. So I would say that would be my key takeaway.
One point I believe is important to touch, because anytime that we enter in discussion about for example, interoperability, sharing of data, sharing of the information that stay in the EMR, stay in the national registry, stay in many, many different, let me call database. The problem is the semantic understanding of this information. That's the main point. Because if you read a report of the radiologist, it's a blah, blah document. If you read a discharge letter, it's not a blah, blah document. With a blah, blah, it's impossible to analyze the data. With a blah, blah, it's impossible to apply artificial intelligence information. With a blah, blah, it's impossible to use the secondary. We can use the data for the secondary approach. Then one of the main problems is to promote a semantically campaign, let me use, to give the possibility to simplify dramatically to the doctor and nurses the production of comprehensible informations, semantically tagged information. Otherwise, we will remain only in the Congress, we will remain in the newspaper, and we will remain the dream. That's another very important issue that we have in front of us. Fortunately now we have many tools that can help the doctors to codify correctly the information without a big effort. Time is a cost for the system. And then sometimes we need to arrive very fast to finish that specific activities. And we have the time to correctly codify the information, to prepare the information to reuse in other object. That's another very important issue. Fortunately, now we can help our user. For example, we have more than 10 million doctors that are using our system. If I ask to them, are you ready to spend more time to correctly codify the information? They say, no, I have enough time. Then we need to simplify dramatically their life. Otherwise, we will remain in the theory again, and nothing really sustainable and significantly usable we will have. I'm sure that we are at the beginning of the real revolution, but we need to go fast in this direction with the big investments. That's a big problem. With a global cooperation between the public and private institution and organization, because the cost of the R&D in these activities is not trivial to arrive to simplify dramatically this job. If we arrive there, we change dramatically the medical activities for the future.
Thank you. Tamer.
Thank you, Dr. Gupta. I want to mention one more aspect of the way that Meta operates in the health space. I've mentioned our billions of users and the engine that the platform is for participatory public health. We ran a survey during the pandemic to which millions of users volunteered to participate. And this was a population-based survey, eventually had over 120 million responses and became a leading source of information for countries and other stakeholders when they're responding to the pandemic. So, and the success of that then has led to another survey platform that we're launching now with University of Washington, University of Maryland, Ludwig Maximilian University, and 18 countries. But the point of that, I think, is that we are demonstrating that digital health works, and it works in multiple aspects. And so my main message is that access to care drives positive health outcomes. Connecting people to accurate information, support, and services, including in the digital world, enables access to care. So Meta is fundamentally about connecting people to things they care about, including health. The technology companies have immense potential impact if you work with us to tailor our offerings to the challenges before you. So we've demonstrated that it works, and we can do this at the scale of millions and even billions. And so that's why it's time that digital health solutions are built into every health program. Digital health is health, and it's time that we treat it that way.
Thanks, Omar. Omar, your quick takeaway.
Sure. I think it all stems from identifying the opportunity and getting the G20 to align on the vision. The vision is, if you implement digital health, it has an opportunity of 1.5 trillion saving or reallocations of these funds. It has the potential of 40% improving in access, especially in hard access to get countries. It has the potential of addressing the skills. Now, there are certain root causes for why the adoption of digital health to the extent that we want is there and it's not happening. One of them is about the reimbursement, the sharing of data, the lack of skills. Today, we continue to see healthcare as doctors and nurses. I'm a doctor by background, but I think the future needs to be shift from that. Doctors and nurses will continue to be needed, but nevertheless, we need more engineers, more data scientists in healthcare. I'm a doctor and a surgeon, and I see most of the solutions that we face on daily basis with the advancement of technologies not going to be sorted out by a brilliant doctor in the future. It's going to be sorted out by an engineer who will be designing a solution that will do whatever the doctor is doing today. And we need to shift it. We need to reskill our doctors to be fit for the future. And in order to do that, so I think that there are recommendations that the G20 need to take. One is a shift from a focus on attempted cure. We need to do like the UK. The UK went straight away and said 20% of our budget is going to go prevention. No questions, no discussion. This is a commitment they are going to make. 20% is a lot of any budget. And they put it in the front. Prevention is key. Today, we are facing
a situation where the biggest impact on public health didn't come from large international organizations or public health doctors. It came from technology providers. Our wearable is having more impact on my public health than the many advice on the documentation we can see today. Facebook is having more impact on my public health or my health than many of the, it tells me the sources, tells me somebody who's doing A, B, and C. We need to do that. We need to, second point, which is integration of data. And the data is not the one sitting in EMR, it's not the one sitting in HIE only, but even at some point, the one from our wearables and the one that is on my social interactions. Another one is we need to move from a commitment to not have a tokenistic digital experience initiative. It needs to be a digital first healthcare. You design your healthcare accordingly. It's a digital first, design it. If necessary, then it goes in person. Obviously, it's important to have it in person, but let's our design for the future be digital first. Let's identify what's the telemedicine. Brick and mortar is there, but I think it's on the way out. I think telemedicine is one, having the patient at the center of the experience, the owner of their own data, which will bring me to the other point. The process optimization, do not use digital to process optimize. Use digital to revolutionize healthcare. Today, when we are looking at clinical research, when we are looking at new initiative for the healthcare of the population we serve, we need to think about digital. Gone the days, or they are on the way out, of coding your information on a paper and sitting on the most brilliant professor in the hospital. It needs to be available for everybody. Democratizing your data to make it available, aggregated, and allow even the smallest of researchers sitting in the middle of nowhere with no access to equipment to do research, to have research on digital. Last but not least, it needs to be, I think, person validated and internationally recognized digital health passport. I can take it with me wherever I go. It allows me to do that. Take it with me and then aggregate it for the use. It's a pity that Giorgio is saying they have access to 1 billion, but I'm guessing these 1 billions are pretty segmented. You can't do anything with about 1 billion population if there are 50,000 here, 40,000 there, and 60,000 there. If we are going to develop the insight, it needs to be aggregated. It needs to be allowed to be aggregated. And I think these are the recommendations for the
Thanks, Omar. We're running out of time, so I'll ask Elaine and Bert to quickly give their comments.
Thanks, Raj. Yeah, these are very insightful and profound reflections. Clearly, investments in preparedness and prevention is key here. The speed of our responsiveness has to be paramount. And we need not only human collaboration, but data collaboration, as you've all mentioned. It's exciting to hear the enthusiasm about both sharing resources from Google and Meta, but also this idea of digital passports and things that WHO is actively working on. So to have enthusiasm from the group is really fantastic. But I think, as Lakshmi pointed out, we really must learn from the pandemic. Some countries got it right, other countries got it wrong. And we need to actually examine carefully what were the ingredients that had to be in place before the crisis, sometimes years or decades before the crisis, in order for that country to be able to respond effectively. And so learning from the pandemic has to be our key objective at this current moment, so that we know how to go forward. But I think the one thing we do need to have a clear focus on is equity. We want to ensure that this digital revolution and that all of these innovations that we're talking about leave no one behind. There's a digital divide that we are all cognizant of, right? Despite the penetration of Facebook and Google technologies, there are still substantial portions of this planet who are unreached by technology. And so as we develop and invest in these technologies, we also have to think about a rising tide. How do we bring more and more people into the digital fold, so that the vulnerable, those who are disconnected, are often those who are most vulnerable. How do we ensure that they are not left behind? So that means intentionality in design, intentionality in the development of these programs and digital initiatives. And for technologies like AI and big data analyses to be effective, we must be sure that representation of all segments of the population are in those data sets, right? As you mentioned, Annalisa, flawed data sets lead to flawed conclusions. And so I think, we need to ensure that inclusiveness, that equity is paramount in our thinking as we move forward.
But before you get to conclude, I have only one submission which I gave to Alan because he's going to be at G20. Please ensure digital health for all by 2028.
Thank you.
Yeah.
Thanks very
So,
much, Dr.
yeah, Bert, sum up.
Thank you, Professor Gupta. Many strong recommendations have been made. I would like to add one more, and that is about the people in healthcare. People in healthcare, doctors, nurses, they joined healthcare for a reason. They joined because they want to make the world a better place. They want to treat patients. They want to give people a higher quality of life. They want to avoid disease where possible. We need to make sure that these people continue to be as passionate in a digital health world. They need to be able to use these systems as designed so we get the data that we need. They need to be comfortable. We need to actually make healthcare more attractive than it's ever been because of the digital part of it. We need to think about attracting new people to healthcare because of the digital part of it. We need to really move on where we have had great success in allowing doctors' handwriting to become legible by making it digital. That's the first step, indicating how healthcare can actually improve. Now we need to make sure the data becomes available for generating these insights and giving us this line of sight on what's happening, pandemic preparedness, or general incidence of disease. And that should be in people's thinking about joining healthcare, staying in healthcare. So my plea is very much on educating people, equipping people, and make healthcare more attractive than it's ever been because of the digital transformation.
Thank you, Bert. 2 questions. We want to make sure we hear from the August audience as well. You want to put to one of our expert panelists? If not, before, yeah, Angela.
Thank you very much. I was just reflecting on the enormous opportunities that are available via making healthcare digital, but also the enormously dark side of the internet data collection and trust, particularly as it's manifesting itself on the doorsteps in my constituency, where people were convinced to be anti-vax, believed vast amounts of conspiracy theories about where the virus had come from, or indeed even if it existed at all, and thinking about the kind of world that we're in now, and thinking about how I might explain to my constituents that they ought to hand over all their health data so that even though it's anonymized, it can be used globally. That's quite a big ask. And nobody's reflected on the skeptical side of this debate so far. So I thought I might just ask for any observations as to how that side of things can be dealt with, and how people's natural mistrust and distrust, how the fleeing from truth and facts, which we've seen become a very dangerous part of our politics in the last few years, can be dealt with so that we can achieve the potential that digital health presents us with. Thank you.
Thank you. Anyone wants to take this to respond? Anna?
Yeah, I'd be happy to take it. So first of all, I'd say there's stuff you can do now with the data that's available now. You don't have to hand me the keys to your house for me to help build something nice in your yard. So those tools are out there. Let's do what we can with the data people are trusting us with. They're giving us their Twitter feeds. They're giving us their location. They're giving us information in that way. There's stuff we can do medically around that. On the second side, in terms of trust, and misinformation, we did actually this extensive study around misinformation analysis. And there were some key factors, and some of them come from the political side. So the study that we did in the US, one of the strongest indicators for something around misinformation had certain politicians' names associated with it. It doesn't mean they said something, it just means it's a very strong indicator. So the voice from the top down is extremely powerful, but also the community voice from the bottom up is really interesting. So it needs to come, that analysis needs to come from both sides to see where their locations are, and to understand what the community is saying.
Thanks. I'll add just one thing, on this. In the age of 240 characters or Twitter, if I have to fill 15 page of acceptance of the settings for joining any platform, it defeats the purpose of my trusting that. I think that also needs to be addressed over time.
But I think it should start from the notion that your constituents are absolutely right. So at the end of the day, I think I'm not exaggerating if not everybody in this room do feel your constituent. It's my data, it's my personality, it's something personal to me. You feel violated every time you go. Sometimes you do Google search, you enter your website and suddenly a pop-up message saying, this password has appeared in a list somewhere, do you want to change it? And you go, well, thank you very much for alerting me. So this is to give you the potential of what the data can be used for, but it's a risk. And I think it needs to be managed against the benefit. At the end of the day, it's a risk that shouldn't stop us from doing something, but rather should encourage us and push us to put the right things in place to manage it effectively and very strongly. Similar to a doctor treating a patient and has to provide the best care because this is a patient's life at stake. It's us as decision makers, policy makers, or technology providers need to take that very seriously. This is an individual, this is a human, this is why we exist every day.
Thanks, Omar. Keeping up a commitment, one quick question with a quick response that shouldn't be run out of time. Yes, Power.
Thank you for the opportunity. I would like to thank the speakers, and I would like especially to address my deep congratulations to Dubai, because I'm very impressed. But I'm very impressed by all these results with digital health. However, I would like to know how all this is organized, mainly in regard to the legislation, because here we talk about data and mainly personal data. Thank you.
Anyone comments, response? Yeah, Omar.
I'm guessing, so Dubai, Abu Dhabi, all the same. We're all UAE. But from Abu Dhabi point of view, I'm conscious I'm talking to somebody behind me, but I'll do that. That's okay. Data privacy is very important. So the first thing when we started the journey, there are two key documents that started, which is one about the data, how to manage it, who has access to it. I'll just to give you an example. So if I'm sitting in Abu Dhabi and there is a doctor in another hospital is accessing my information because they are doctors, they have access to the EMR. I get a message straight away into my phone saying, such and such is accessing your information. Would you like to allow or deny? So if I'm sitting in front of the doctor and they're saying, would you allow me to access your information? I'll say allow. But if there's somebody I don't know about, I'll say deny, and that straight away go into investigation why that person or that doctor or that healthcare provider is accessing my information. The second element, especially was pertinent, is about getting all the systems to talk to each other. So one of the key policies that we implemented is what we call the interoperability. So we have lots of EMRs in different places. We have about 1,500 healthcare providers, different EMRs at different levels of maturation. And we ask them, if you want to be part of the network and to be paid, you have 2 years to upgrade your system to that level. It's an investment you need to make. Nevertheless, we do see the potential of that investment, not only in improving patient care, but also improving your services and efficiency, and you will recoup it in the latter stage. And that get everybody to have a certain standards of interoperable, it's a very strong word, very heavy word, interoperable system that allowed us to do the health information exchange. Last but not least is the latest policy we issued first in the Middle East, which is about the use of AI in healthcare. What it does, and we fully appreciate it, we needed to take a stance on the use of AI in healthcare. How do we regulate it to a level that realize its full potential, but at the same time be conscious of the ethical implications of it? But needless to say, these policies has to be updated all the time. Technology is moving so fast that whatever policy you put today, I can guarantee you they will be obsolete in 6 months or 12 months time. So you need to catch up and involve the technology providers into designing them and implementing them. And I think for a success in that level.
Thanks, Omar. With that, I'll have to end because we're out of time.
Can I suggest to read the last version of the European health data space document that is a fundamental document in Europe for the data portability in a healthcare environment. 2 fundamental points, premium and penalties, because the main problem is regulatory legislation. In Europe, thanks to the evolution of the GDPR, we will have the clinical data portability in the next years. It means that when you produce, like a provider, in the hospital, in the lab, in any place where you produce a legal clinical document, the patient can ask to move that information in the technology standard where he decides that he wants. And if the provider don't produce this document and don't deliver this document, he pays till 4% of the global revenues of their organization. Of course, we can also discuss what is the best, but without practical law, no way. Because who is the people ready or the organization ready to put in place their effort? Because the cost to produce this data is inside the organization. Only if exists a regulation, you can really go ahead in the real interoperability. Otherwise, it remains in the sky.
Thanks, Giorgio. We have to end this. Thank you. A big round of applause for my expert panelists. And thank you, Alan. Over to Ali.
Ladies and gentlemen, if you're looking carefully at the program, there's no break here. We're gonna have a lunch break at noon, but for the next 60 minutes, and may I ask the speakers of this next session to come up front, to come and join me here in the circle. Slowly, but this is the flying exchange that we're doing. Exactly. Yeah. So the speakers of this session, please move up. Why don't you?
Thomas Cooney and Bill, can you move up a bit if you don't mind?
So if you are a speaker in this upcoming session, please move up. Please move up to the circle. Because I can tell you, we actually have quite a challenge here on our hands now with this upcoming session. Lunch break is going to start at 12 and we have 8 speakers. So I don't have to tell you that time management and timekeeping will be of the essence here in this session. Nonetheless, of course, it is a very pertinent and timely one titled, "What are the global best practice initiatives developed in G7, G20 and beyond during the pandemic?" We will ask, how can we make them more sustainable, strengthen efficient multilateral and cross-sectoral cooperation? That is the session, the task that we have. So I would kindly ask our esteemed speakers to be as precise and disciplined as they can be in their remarks. And let's start right away, Saleh Al-Ali. Delighted to be joined by you. He is, of course, with the Department of Health in Abu Dhabi. There he is an executive director of the Emergency Center. Saleh, it's wonderful to have you with us. From your perspective, in recent years, multilateral organizations have created a multitude of global health initiatives. And in this session, we want to explore how these initiatives can be turned into concrete actions. What has been your experience?
Thank you, Ali, and it's great to be here. Definitely, I think, based on what we've been hearing for the past 2 days, collaboration and cooperation and communication, I think, is so key. This is something that we need to keep repeating all the time on to the different levels, especially to our politicians. Looking horizontally from an emergency management point of view at the healthcare, we could not succeed without this communication and collaboration with the different sectors, not just within health, but with the other sectors, in terms of, security, government, politicians, and so on. Working with the WHO on the Act A, I think that was a very important initiative. This is a main collaborative effort that showed the world how governments, scientists, academicians, businesses, civil society, and others could work together toward the bigger good. We're very proud to be part of it. This is definitely saving lives, and to me and to us and to many of the bigger community, I think this is a very successful project and initiative. We want to learn from what challenges have we faced and take it to the next level on how we prevent and work on the next pandemic. Another lesson that we should learn from the Act A is also broadening our spectrum. We don't want to just think of outbreaks and pandemics. Emergencies and disasters happens all the time, so we would love to broaden that approach into more of an emergency management within the healthcare, and that by itself involves a lot of the other health and non-health partners as well.
Thank you so much for your first input. We're going to make the rounds and come back to you, of course, as we take a deeper dive. But for now, let me turn to Marie-Ange Saragaya Yao. She's the Managing Director and Director of Resource Mobilization at Gavi, the Vaccine Alliance. Certainly a lot you can share with us here, some of the best practices that you have encountered and experienced.
Yeah, and thank you. And it's really a pleasure to be here. Definitely close and targeted collaboration is the key here. I think if we reflect indeed on Act A, what we have to remember is that at the time we didn't know what will unfold, what type of responses we could have. So really leveraging the organization that actually do it and bring them together. And I think, as one of the speakers in the earlier panel said, really bringing from different spectrum, the financier, the countries. I mean, ACTE has now more than 146 countries, if I'm not mistaken, probably bigger than the Paris Accord. The various partners, and some of them we had worked together, but some we hadn't. So it was really to look at developing swim lanes. What can work, what cannot work. At the same time, leveraging the networks, the existing one, new ones. At the same time, thinking about financing, but most importantly, at the same time, thinking, how can we deliver if actually this instrument works? How can we already start preparing the countries? Again, we heard over the past 2 days how thinking also about the end view. And it was really having, I think what's unique here, it's really having an end-to-end view, from the development and the financing to how you deliver. And of course, bringing also the pharmaceutical industry, different type. I think what it brought is, information indeed, but just in time information, because the issue was speed, we have to remember, uncertainty, and being able to pivot. And I think that has been critical, and I think makes actually ACT a very powerful platform in terms of coordinating body to address this type of challenge. Of course, for the future, certainly a type of coordination mechanism like that may be appropriate, particularly for the nimble and flexible structure. But I think what we have to be mindful and be careful is that as we think of maybe bring a little bit more formality into the structure, not kill that nimbleness and flexibility, because next time it may not be the same type of pandemic. So we have to be mindful of, how do you say, recency bias. So the key is really to have that nimble, flexible structure that can bring all kinds of partners, including the private sector, including technology companies with whom we work with. So I'll stop there.
Thank you so much, Mary-Ange. We're going to circulate and revert, obviously, to all speakers for a second round. But Thomas Cooney now, I want to call upon him, the Director General of the International Federation of Pharmaceutical Manufacturers and Association. Thomas, good to have you with us. Share with us some of the best practices that you have encountered during this pandemic.
Thank you very much. I think when we want to look at what worked well and what didn't work well, we should also look at what didn't work well, because sort of Marie-Ange already hinted to that. We had to build the plane while we were already flying. And I think there we clearly saw that we benefited from some pre-existing structure. I personally have been most involved in COVAX, and I've been regularly involved in the ACT-A principles. Something which many people forget is that COVAX and the COVAX coordination meeting was actually conceived before the ACT-A principle was conceived. And I think one of the elements in terms of future global pandemic architecture, which I consider is really important, is the notion of subsidiarity. I'm deeply convinced that it's much easier for organizations such as Gavi, UNICEF, CEPI, with WHO to do fundraising for the vaccines than it would be to have a collective ACT-A pot. And I think that's something which would be dangerous, because we were relatively successful in fundraising, but at the same time, we had to recognize in COVAX that COVAX was handicapped at the beginning because it couldn't spend money before it had the money in the bank. It couldn't sign the advanced marketing agreements, and that was a big handicap, which had an impact on equity when it came to the export ban, for instance, from India. I also think it's important that in all these endeavors, one really respects that the private sector, whether it's from industrialized or developing countries, was critical in bringing the tests, the vaccines, and the treatments to the fore. And I have to honestly admit, 3 years ago, I had no clue who Sai Prasad, Mahima Datla, let alone Rajendra Suri, who is now the CEO of the developing country vaccine manufacturers. We became friends because we had shared objectives and we felt respected in COVAX. I think it's important that, for example, in the therapeutics pillar and in the overall ACT-A, that we do use these lessons and we do involve those who are critical for bringing it. And I have to admit, I never felt the same in the therapeutics pillar. We can go into more details later. And of course, the health systems pillar, which would have been crucial because at the end of the day, country readiness, lack of absorption capacity, health systems is crucial. For me, the health systems pillar never really took off for whatever reasons. And if we don't fix that, we will fail again. And last but not least, I think it's important to give a strong role to WHO, but WHO is strongest in its normative roles, in the rule setting, in the medical guidance, in the regulatory. I can only praise Emma Cook and then Rogerio and Mariangela for the speed, the ease with which they really helped to get emergency use licenses. But if WHO is tasked or wants to run operations, honestly, That's where Gavi, UNICEF, FIND, and others probably are stronger. And we need to be honest with each other, admitting that.
Honesty is certainly a key here. While we do want to speak about the global best practice initiatives, it's also important to highlight and mention what didn't work. So thank you, Thomas. That's obviously something that needs to be taken into consideration as well if you want to come up with a full assessment here. Let me turn to Janet Ginner now, the head of strategy at Unit8. Thanks so much, Janet, for being with us, and looking forward to getting your take as to how what you perceive to be a best practice here, what worked, but also perhaps what did not.
Sure. Thank you for the opportunity to speak and to share some thoughts on this. Very much top of mind and continues to be. I think in terms of what was most helpful about the ACT-A collaboration, I think really it's that unprecedented collaboration, cooperation, the start of some new conversations, aligning priorities and clarifying roles and responsibilities, contributions, what each actor could bring to the table, how that could fit together, even as so much was unknown. I think the articulation of those collective priorities, of real honest conversations, each agency coming and saying, this is what we can do. How does this come together and contribute to a greater collective good? As Unitaid, we saw real value in articulating that end-to-end thinking, as Marianne had clarified, really taking immediate action at the same time as taking steps towards more resilient health systems. We saw the importance, and we recognized early on the real value of decentralized test and treat, what that was going to take, the value and the key of having access to oxygen, and really that spotlight on access. And I would be more precise in saying equitable access. And that cannot be an afterthought. It has to be built in from the initial conversations, and is really key to sustainability and impact. And so on that sustainability question, naturally any mechanism like that arose in response to and was forged in crisis. I think naturally there are elements that should evolve, but I would hope that we can retain a lot of the value and the strong points of that. I'd hope that the sustained legacy includes continued earlier, better engagement of communities, civil society, country stakeholders from the outset, and consideration of the evolving strategy and what that can look like across diagnostics, therapeutics, vaccines, and how those can all be used together in the context of more resilient health systems. So I think there has been a tremendous amount that we've learned, more that we can and should take forward, and excited to hear how we're already thinking about, as Unitaid, but many of us around the table thinking about contributions to the FIF and other future potential mechanisms. Thank you.
Well, thank you so much, Janet, for your first intervention. I'm going to come back to you in just a little while. Let me turn to Bill Rodriguez now, the CEO of FIND, the Global Diagnostics Alliance. Bill, what has been your experience throughout the past 12, 24 months?
Yeah, I joined FIND and became a member of the ACT-A Principles Group in the midst of the pandemic. So the ACT-A mechanism had been up and running for over a year. And I would say I was immediately struck by one thing that the ACT-A mechanism was singularly effective at doing it as a best practice. And that was establishing a real-time rapid response mechanism, right? It's been echoed by what Thomas and Marianne and Janet said, but for the first time coordinated by WHE and the DG's office, but incorporating all of the major global health agencies based in Geneva. On a near daily basis, we were sharing information about the trajectory of the pandemic, what we were seeing on the ground, the development of the tools, the barriers, and the challenges. And given the pace at which COVID moves, if your response mechanism moves slower than the pandemic, you'll never catch up, right? And to see that established as I came into the middle was really, I think, a critical practice that had been established and I hadn't seen before. I think most of us have not seen before. Now, at FIND, we have a saying, which is we never make the same mistake 8 times. And so if you have a rapid response mechanism, that's great, but it doesn't mean you're effectively responding. Are you doing the right things rapidly? And I think we saw a number of mistakes that maybe we've seen before in the response to a pandemic. And I'll just highlight 2 for now. The first is we were not directly connected enough to what was happening on the ground. Our ears were not attuned to the ministries of health and finance and the COVID task forces that have been set up in every country on what their issues were, what their agenda was, and what their needs were. And as the pandemic evolved, and as the information from the ground was critical, we had our partners, FIND and UNITAID and Global Fund and Gavi, all had our partner networks that were in country. We had new partners, but the coordination ACT-A mechanism, that rapid response mechanism that was coordinated here, was not getting that information directly enough and frequently enough to evolve with the pandemic. And I think we've seen that mistake before, not being as close to the ground as we need to be. The second mistake I'll highlight is ACT-A was about tools, and as we all know, tools have two phases, tool development and tool delivery. And in the first part of the pandemic, appropriately, we were focused on tool development, the unprecedented speed at which the private sector developed these tools, diagnostics, vaccines, therapeutics. We were focused on making sure the clinical trials, the regulatory mechanisms, the procurement mechanisms, the financing were in place appropriately. But as it shifted to the delivery side and the access side that Jana talked about, we maybe didn't react and develop and evolve quickly enough. And it's linked to that first point. We weren't focused on the ground. We were focused on the tools and the tool makers more than the communities where the tools needed to be delivered and used. And I think we've probably seen that mistake before. So I'll just finish by saying, maybe it's not the seventh time we've made that mistake, but it may be the third or fourth or fifth. We can learn. And as we think about the future mechanism that really maintains this incredible real-time rapid response, we want to make sure it adjusts to some of those learnings about being connected to what's happening and focusing, not falling in love with the tools, but falling in love with the delivery of those tools.
Certainly, deriving the right lessons from what worked, but also what did not work is crucial and elementary into making sure that these lessons are being applied all across on the multilateral and cross-sectoral cooperation. Of the 8 speakers, we've heard from 5. Thank you so much to all of you up until now for being extremely disciplined in terms of your delivery. Let me turn to my left to Osama Kouni, who's the CEO and Executive Director of the Global Health Innovative Technology Fund. Osama, good to have you with us. Let's hear your experience.
Yeah, thank you very much. Actually, I joined this GHIT, we call that 6 months ago. And before that, I was a division head of the Global Fund. So I also want to share that my experience of ACTA and several others. ACTA, as many said, it is a really great, the collaboration. But at the same time, we also got a lot of lessons learned, especially the Global Fund was belonging to the diagnostics, therapeutics, and the health system system connectors. I can say system connectors not kind of working very well. So we really need to look at how we can connect, between those kind of very important one. And also a kind of coordination is a bit kind of challenging. And we really need that, very rapid coordinated planning and the role of a demarcation. And of course, there are kind of variety of things. So we really need to learn. And actually, before this, the ACTA, we have already the cluster approach in a disaster. Actually, I was working in UNICEF, so I had been a coordinator of this one. So cluster approach gives a lot of good lesson actually, but it was not so much kind of applied in this one. For example, we have a variety of clusters like the communication, food, and the nutrition, etc. And actually, this, the COVID response is very much medicalized, I can say. And actually, in the region and the country level, there are a lot of issues of food security, water sanitation, etc. So I really recommend that we also need a kind of a multi-sectoral approach, learning from cluster and also country level and the regional level. Actually, maybe later I want to say for future, but there are very good movement for the regional ownership, leadership, country one, etc. And the other one is maybe 100 days mission. Actually, I'm also advisor now to a G7 summit the next year in Japan. And we set up the 3 working groups now. One is a working group for the facilitating this 100 days mission. Second one is UHC, and third one is governance. Maybe still, kind of working group, and we really need your kind of inputs and suggestion. But anyway, we really need to kind of make a good progress in this 100 days mission, but not only research and development, but alignment between research and development and access and delivery. And I personally want to include that existing, research and development, access, delivery of existing, unmet needs of, HIV, TB, malaria, and even neglected diseases. Maybe I can tell much more kind of detail later. Thank you.
Absolutely, Osamu. I will come back for at least another 2 rounds, depending on the time management. But thank you for now for your first input and intervention. Let me turn to Johan Weckemans, who's a senior science and clinical advisor for the International AIDS Vaccine Initiative, which is a product development partnership organization aiming to take candidate vaccines against global health priority targets from discovery to approval. And Johan, you are an expert in vaccine R&D in the context of multi-partner collaborations. You worked on the front line of COVID-19 development. Curious to hear your assessment and what you perceive and have perceived to be best practices. What has worked, what has not?
Thank you very much. And indeed, I think I would like to insist on the importance of considering capacity and access as really a continuum of what emerges in the field of health solutions from the R&D ecosystem. And when we talk about equity, we shouldn't be considering only access and implementation, but very much we should think about it all along the steps of this end-to-end ecosystem that leads to creation of innovation and availability of new products. I have indeed been very privileged to be part of the implementation of research program of COVID vaccines, but also of malaria vaccines. And I want to highlight the fact that the COVID vaccine experience took about a year from first human administration to licensure. And the project on malaria vaccine development I've been involved with, which is now a vaccine that is now recommended by WHO, took over 35 years of development. And I would like to remind this audience that we have a TB vaccine that was put first in use over a century ago. So it's interesting to apply some comparative metrics as to what leads to success and speed in these environments. And clearly, I have to insist that it has much to do with political commitment leading to resource mobilization, and then turning the consideration about what is the need into change in our ways of working and adapting the tools to the vision and to the need, rather than being restricted in where we want to go just by the processes. And it's not just about the money, it's about the ways of working. Being able to work in parallel rather than sequence, it increases the risk. But that comes with the ability to have success faster or the ability to fail faster, which has a lot of value. It's very expensive to keep ongoing programs that ultimately fail. So a very end-to-end perspective, extremely important. And there are organizations that can help that. Product development shouldn't be left to single, even big organization. There are product development partnership organization whose really reason is to put stakeholders, partners together, and that dialogue is absolutely key to make sure that at the end of the day, the business model is sustainable and supports global access. So these were a few points that I wanted to insist on.
Thank you so much, Johan. You mentioned you were not just on the front of developing the COVID-19 vaccine, but also malaria, which is a nice segue to my next speaker is David Reddy. He's the CEO of Medicines for Malaria Ventures. Clearly, David, the focus in the last 2 years has been on COVID-19 for a good reason, but where do you see parallels? Where do you see best practices? What was your experience of use throughout these past 24 months?
Okay, thank you. I think there are a number of parallels. So firstly, if I start with ACT-A, I mean, ACT-A was, it acknowledged that you needed to bring together a diverse group of different entities in order to succeed in this environment. It was extremely inclusive. It provided a very good architecture for working together and processes for working together. It had a sense of urgency, and funding was able to be deployed against priority areas and projects very rapidly. I'd just like to acknowledge the strong role of some of our sister organizations like CEPI, FIND in that process. Extremely important. For the other product development partnerships like us, what we were able to do was we had existing partnerships with industry, with various research institutions, and also with our partners in low and middle income countries. And we were able to become something of the glue to effectively help join these together and strengthen the response. Clearly, there were deficiencies in terms of capacity and in terms of access to some of the key interventions that were required. And for malaria, particularly personal protective equipment. And I think the conflict or rub, if you like, between the need to personally distance, but on the other side, the need to continue with the community care programs in malaria. That was a tension that had to be resolved, and WHO did an extremely good job of that. So ACT-A had a really strong role, but if I can just draw a really quick parallel, and that was behind this, WHO did what I believe to be an absolutely fantastic job of bringing together all of the key actors and the countries involved in malaria, and dividing up responsibilities for things like commodity tracking and management, looking at the clinical implications of COVID and malaria, etc., and to real time and intensively manage this to try and avoid issues. And I think if there's an unsung hero here, GMP at WHO did a tremendous job of steering that ship and helping us get to a position where, yes, we had increased fatalities from malaria, and it could have been so much worse. Thank you.
Thank you so much, David, for your initial remarks and the shout out to the people who were at the forefront of this very crucial development. And Salah, let me turn to you for the second round of this very interesting debate about global best practices and multilateral and cross-sectoral cooperation. Aside from asking you about the recommendations that you personally have, also the way how we move forward. I mean, we talked a lot yesterday about whether a new pandemic is going to come is not a question of if but when, and the time gaps are getting closer and narrow as we speak. So clearly, some of the lessons that were drawn throughout the past 2-3 years need to be applied here, whether it's the north-south divide that we've seen in terms of initiatives created, whether it is about breaking down the silos in the health industry, whether it is about vaccine hesitancy, all these elements that came through and were phenomenons. So my question is to you moving forward, and that's the focus we will take, looking ahead of what is expecting us. What are some of the key points, Saleh, that you think we ought to be focusing on?
Sure, Ali, and I think this is definitely a learning curve for everyone. Just moving forward, as everyone agrees, that we want to look back and learn and move forward in a much faster and collaborative effort. As Thomas mentioned earlier, there are things that we should learn from our mistakes, but also best practices that we could learn from. So looking at our own ecosystem in Abu Dhabi and the UAE, there's many good examples that we would I think we shared with the world, but also it's always a nice forum to mention. Getting the equity, personal experience, and also a government official, and being living it firsthand. Early on in the pandemic, when everybody was in a shock, that nervousness in the community, you could feel it like at your house, in your community. So when you feel your government is there, so there was a very nice statement from His Highness the President, Sheikh Mohammed bin Zayed, very casually, very reassuring. In Arabic, la tshilun ham, and this is don't worry. So that was a very nice statement that really spread across the community.
Everyone was reassured that I will have access to food, I will have access to medication, I'll have access to the best care possible. And being again in the healthcare, I lived this. I've seen, the sickest of the sickest, illegal citizens, immigrants, tourism. There were no questions asked. Who is he? What's their name? Just give the full care and do it as much as you can. We've spent so much on helping, COVAX, $50 million or so participated on. Over 80% of the humanitarian global aids passed through the UAE. Over 1.6 billion vaccines, again, going through the UAE overall. A huge infrastructure that we can participate in globally. This is not showing off. This is actually offering services and participating, putting our hands out that we are here to help. This is all, as H mentioned yesterday, whole with all. Honestly, everyone could contribute and should contribute to what they have. We're a small country, but we do have infrastructure that we can contribute. Over 6 billion storage capacity with ultra cold. So that could easily help, at least in our region or globally. Ability to vaccinate, best practices. We were vaccinating over 150,000 a day. Over 150, I think, outlets for vaccinations just in the Emirate of Abu Dhabi. Numerous field hospitals, best practices in terms of deploying. Dr. Omar mentioned the digital health. That was phenomenal. And that was pre-pandemic. The stockpile itself, I remember we've been working on it since 2015 or so. And we did not suffer the shortage that the other countries have done because we just thought ahead just for our own country. But again, it helped that we help our other countries. So the lesson, I think, is sharing practices, working very genuinely together. We're all together in it. We're in one boat. The stronger the communication together, the better we're going to move forward and in a very much faster process.
Swim together or drown separately. I think that's the theme that we heard yesterday, and one you are reiterating here, obviously, that collaboration. This is not the time to slow the pace on collaboration, but rather pick it up. Mary Ange, also, let me get your take on the way forward. How do we move forward with the many best practices and new experiences that we have under our belt?
Yes, thank you. And I think I would highlight two key actions going forward. We heard we learned a very hard lesson in ACTE, is that the time value of actions during the pandemic is enormous. And whereas, as Bill was mentioning, you can develop try to develop a perfect rapid response mechanism. What became very clear is that the world was not ready to deploy funding and cash rapidly to get access or to help get access to these instruments. So there's really a need for pre-arranged financing, especially at risk, because of course there was a tremendous solidarity, but by the time, all these things and the time it takes, and Thomas alluded to it, then the products are not, especially in a supply constraint environment, are not necessarily available. So you do want, like the high income countries, to have access to the product when they are in development phase, to have at least a take and be able. So I think that's very important, to have this type of pre-arranged at-risk financing. Of course, we heard this morning from the G7 and G20, there's been already effort made with the fifth, but the fifth is more focused on the preparedness and how to build more the system, but the response still need an active mechanism, financing mechanism. On our part, for example, in Gavi, we have this mechanism, front-loading mechanism, EFIM, that many of you are familiar with. The idea is to be able to link EFIM with contingent pledges so that the moment, a crisis occur and the trigger is thing, we can call on it. Of course, there's also being able to tackle, some of the banks, the corporate banks and the regional banks and other banks leverage their balance sheet quickly in a similar way. And we are in discussion with EIB, DFC and others. So I think that I just want to be clear that while there's an instrument that will focus on preparedness. There's work to be done upstream also. We really need to look at the value chain. The second, of course, key thing that we have to focus is on how we further diversify the manufacturing, right? The manufacturing capabilities. And here again, I think we have to think also about a holistic approach. It's not just about opening plants in various countries because they won't necessarily be sustainable. It's making sure that we have a market shaping strategy, which means that you have a sustainable supply, but it's affordable. And of course, it's about mixing pandemic vaccines and routine vaccines to make sure that you tackle the products that are needed, because pandemic vaccine, as we have seen, have very volatile demands. So you cannot do so there's still work to be done there. And we are obviously working and are committed to work with all the partners here, especially at Gavi, where we have been asked by the G7 and with the partners to draw on a market shaping strategy that is meant to be presented at the end of this month. But I think there are really things to be done. I think we have to, Thomas mentioned it earlier. I think, of course, we always want to have a tendency of going to one single entity, right? And I think Bill alluded to it too. I think we have to be mindful that there's coordination platform, but to be able to go to the people who do the work and have this complementarity also for agility, but also to build on their expertise. And that's very important.
Thank you so much, Mary H, also for sharing some of the insights, workings of Gavi in the Vaccine Alliance. Thank you so much. Thomas Kuhne, you rightfully said that we ought to be looking at what worked well, but also what didn't in order to take the right steps moving forward. You've already mentioned some. What are some of the concrete examples? You are constantly speaking to politicians, to pharmaceutical manufacturers, to associations, to the people at the forefront and decision-making process. Is there a unified front moving forward?
I wish there were. But in terms of, I think we can do more and we can do better to address some of the shortcomings of the response to the current pandemic. And when we look at it, whether you like it or not, equal access in real time for those who need it most was not a strong point of the response in this pandemic. When I look at COVAX, and as Marie-Ange knows, I know COVAX best, the reasons actually are explicable. The first vaccines, significant numbers reached Abidjan and Accra on the same day they reached Tokyo. I was mentioning it to Keizo Takemi earlier this week when I was in Tokyo for the first time in 2.5 years. And it was because COVAX very rationally decided we want to focus on the easier to use, less challenging, cold chain and whatever vaccines the AstraZeneca Oxford manufactured in India. When that, was blocked because of the crisis, the emergency situation in India, and Prime Minister Modi said in March, not a single dose can come out until we overcome that crisis. Actually, it lasted longer than the crisis. It was 7 months. Nothing had come out of the US before July 1. And therefore, the export restrictions were a problem. And at the same time, the companies who were expected to step up, the mRNA, whether it's Moderna or BioNTech or Pfizer, they were oversubscribed initially. And COVAX was not in the front of the queue. Those were the shortcomings, and we all have to ask ourselves, which part of the blame do we have to accept? It's easy, to blame the governments and whatever. We also, and that's why in July this year, and we have come up with what we call the Berlin Declaration for simple reason. We had a global CEO meeting in Berlin. We did meet with the Chancellor's office. We did meet with German officials, and we have since made the rounds. It's straightforward. Companies, whether they're on treatments or vaccines, and I'm sure, Bill, that we get the diagnostics join in there too, commit to putting aside part of available production upfront in real time for vulnerable priority populations in low-income countries. If we would have had that in April last year, we could have fast responded to the Indian crisis. Now, this will not work until and unless we do agree to social contract. José Manuel Barroso, was educated in Geneva, likes the term social contract because of Rousseau, but social contract means that the USG has to accept that part of production from the US will be exported. I haven't seen that to a large extent in monkeypox either, to be honest, and we haven't seen it in the COVID-19, but it also means that India should sign up. I was extremely pleased that my friends from the developing country vaccine manufacturers, whether it's Bharat, BioE, or Serum Institute, they like our commitment, and I'm pretty optimistic that they will join it too. But we need open borders. I'm sure that Dr. Ngozi and WTO will be full force supportive. COVAX and others, therapeutics or diagnostics pillar, need money early on to be able to sign the contracts. And we all need to walk the talk, including my companies, who need to realize that it's more than signing a declaration, it's really delivering the goods to those who need it. With all due respect to the manufacturing initiatives, and we have many supportive actions from companies too in Africa, in Asia, and elsewhere, the likelihood that some companies will be faster than others, and that it does matter, that they are willing to put aside part, I think is huge. And just in closing, I noticed that to some extent, although we never discussed it with him, it is a response to Dr. Tedros' tweet from May, who said and called on companies, please, would you be willing to put aside 10% of production? We don't have a number now, but we really need to sit down with the ACT-A partners and call out to G7, G20, because otherwise we'll be confronted with the same problem in the next pandemic.
Thank you so much, Thomas Kuhne, for your words, your honesty in helping and pushing this matter forward and keeping us all alert, because global preparedness, Janet Kinner, is something that we've been hearing for the past 24, 48 hours numerous times, that we need to be prepared for what is to come. Listening to not just your fellow speakers, but also looking at your work, are you hopeful and optimistic that the preparedness that everybody is requiring, that it is there based on the lessons drawn from the previous 2-3 years?
Sure, thanks for the question. I think some elements are there. I do think that inequities still persist. And equitable access to critical health tools, it's not a new issue. It's in fact the motivation for Unitaid's foundation in 2006, and it's been the guiding light, the North Star of our work since then, and especially given the lack of priority that has sometimes seen in the global health agenda. As Unitaid, we work with many, many partners, including a formidable network of implementing partners, some of whom are here today. And we know what it takes. We ensure the best-in-class tools are designed and are fit for purpose for use in low middle-income countries. We undertake market shaping to secure a sustainable, affordable, resilient supply base that includes licensing. It includes local manufacturing. We ensure community-led work to ensure demand creation, treatment literacy, and we work with partners who can support and spark delivery at scale. We do see opportunities for more and better equitable access across global health, and we see Unitaid as particularly well placed to position that and raise the flag on a few things. A couple of concrete examples where inequity could be better addressed and will be key for future health emergencies. This is sort of zooming out, taking a broader lens. One is oxygen. It's a no-regret move. It's critical for treatment in COVID-19. We've seen that. But it's also a hallmark of functional health systems, equitable access to oxygen. It's a life-saving treatment for pneumonia, for many leading killers of newborns, children, other vulnerable groups. And really, we've seen that in the context of COVID-19, but also much more broadly. So Unitaid leads the Oxygen Task Force. and was really part of a concerted effort with many partners to provide technical assistance to make oxygen more readily available in over 100 countries. We have agreements with 2 of the largest gas suppliers to make that more sustainable, affordable, and readily available in low-income countries. Another area is in women's health. And again, that's zooming out, taking a broader lens. I'll call out cervical cancer. Again, it's preventable, with kudos to Gabby for formidable efforts there. Also treatable, but 90% of the deaths still occur in sub-Saharan Africa. So we can do better. Our programs at Unitaid focus on decentralized screening and treatment of precancer. That's intended to be complementary to vaccine, but both of those efforts are going to be really key for equity and equitable access and saving lives. So just to sum up, I think the quality of clinical care, ensuring that access is not an afterthought, it's built in, it's part of holistic work, and that will include efforts on both the supply side, but also the demand side, and making sure that that comes together. Thanks.
And despite all the achievements I'm hearing, still a lot of work to be done, still some room for improvement, quite a bit. So a lot of work for everyone here around the table and beyond ahead, Bill, no exception for you, of course. Let me get your take on where do you see this going, the developments, and how we need to stay alert.
Yeah, thanks. Let me go back to something that both Sally and I think Marianne said at the start of this round, which is essentially the path forward is to apply an equity framework, and specifically to apply it within the terms of the pandemic treaty that's under discussion and the scope of activities in the pandemic fifth, right? So that's easy to say, an equity framework. No one's going to say, let's apply an inequity framework. So what does it mean? And let me be concrete. On December 4th of last year, I was in Botswana about to fly to Geneva with my family. And a few weeks earlier, the public health scientist in Botswana and South Africa had identified the Omicron variant and submitted it to GSAID. And by December 4th, the world's response was to say, uh-oh, there's a new variant, and they canceled all flights from Southern Africa into Europe. So we were stuck there. Now, on the ground, the idea that Botswana and South Africa had built their genomics capacity, had done the research, had shared the information globally, and been responded to with a punitive measure that affected their economies and their ability to interact in trade and social engagement, was pretty painful and was really not a response that mattered or helped, because obviously by then we knew, in retrospect, Omicron was already worldwide, right? It wasn't just in Southern Africa. So how does that apply to an equity framework? To look at a couple of things that were brought up, the manufacturing base. Early in the pandemic, specifically for tests and vaccines and for the production of oxygen, which Janet just mentioned, the technology that's essential to do those things, to make those commodities and to make the oxygen, were all based in the global north. The know-how, and in some cases the IP, were in the global north. And that meant in the first 6 to 12 months of the pandemic, the supply chains were simply not available to support the demand and the needs on an equitable basis in the rest of the world. So when the treaty is established, rather than saying, let's shut down air travel when we identify a variant, or let's not address manufacturing issues in the scope of the fifth, that needs to be the approach. The equity framework needs to say, if we have production capacity for the critical products that we need, oxygen, tests, vaccines, therapeutics, and we fund that and support that and learn that we're not going to contain the next pandemic by shutting down borders and thinking of ourselves as isolated communities, but thinking ourselves as a global community on an equitable basis, that's what we need to take away from this, because the learning of COVID is the borders really are not the strategy, right? Enforcing borders has not really helped, but maintaining equity in the critical countermeasures and supplies and coordinating globally is effective. And I think that's what we have to do, is apply that really thoughtfully and carefully within the treaty, within the fifth, as we move forward.
Thank you so much. Clearly, isolation, both physically, but also in terms of a concept that does not work here. I think that that's certainly understood based on the experience that we've all made. Osama, let me turn to you again once more and get your take and predictions, if you will. The question is whether we have learned the lessons. There are lessons, clearly. You all have been very generous to share them. The question, I think, is whether we will collaboratively still apply them moving forward.
Yeah, of course. So we have a lot of lessons, but we also need more kind of analysis. That is why we are now working with Wellcome Trust. We are kind of finding the gap analysis, trying to have a gap analysis in this 100 days mission. So they are hiring the kind of consultant to monitor and also find out gap analysis. So based on that, we need to discuss in next year's G7 how to just work forward. And especially we need that shortening that time of research and development. Current PPR discussion is concentrate on vaccine development, but of course we need that the diagnostics and the therapeutics as well. So we also need to make more collaborative effort. And also currently they are discussing that the kind of prototype, that the vaccine on quite corona or influenza, which are quite prevalent in industrial countries. But what about, the pathogens in especially to be prevalent in the low and middle income countries. So we really need to look at, the incentives for that one, or kind of a more put incentive for that. And of course, other one is after development, that how to just make up swift access and delivery, and especially that we need much quicker approval and manufacturing access. And currently I found that quite good momentum to African CDC and the manufacturing in Africa. So there are a lot of efforts going on, but we also need very much kind of collaborative and also coherent effort. Over.
Thank you so much, Osamo. Johan, let me turn to you also as somebody who's very much contributed to the findings and the R&D certainly debate. What is your prediction? What is your take as far as moving forward? We've seen also globally some vaccination hesitancy, clearly globally. Thankfully, the rates are good globally, but there's still some people who are hesitant about it. As somebody who is very much involved in making the vaccine, what message would you have to those that are still 2 years, 3 years into this pandemic, who are still hesitant?
Yeah, it really questions the way we build trust in what we do and finding solutions for health. And I do think that we need to reflect carefully on the balance of our sort of crisis response mode, and when we talk about pandemic threats and sort of catastrophic perspectives, and have the right balance between that and the value of addressing that, as well as addressing sustained problems, the very, very long hardships that communities are facing with endemic diseases. And there's only a certain amount of things that are amenable to change through the crisis mode. Some of it really requires more sustained system improvements. And I think that's key to building trust eventually. I think trust is built early and with a perspective on the whole value chain. I want to come back on the perspectives on inequalities. The inequality and problems we see in distribution system is most apparent now, and tells us that it's not just about access to the product. And so I definitely agree that the initiatives towards regional manufacturing are really good, but they're only a part, and actually a relatively limited part of the solution. It takes more sustained effort to have functional delivery systems, and at the other spectrum, to have an ecosystem that favors local innovation, creation of IP, creation of value. And I don't think we talked about that enough. And so the creation of trust starts very early in research and in finding solutions. And there are some good guidance about how to build trust. It has to do with community engagement, talking to the affected communities, carefully listening to what they have to say, making them actors. And there are some guidance on good participatory practices for research. And we also, I think, reflecting on the past previous discussion, need to reflect about how more strongly to confront the very, very toxic influence on social media and other forum, and the politics that comes with manipulation of public opinion. So these are all extremely important perspectives when addressing inequalities in research and health solution. I want to highlight the very good move into strengthening regulatory capacity including in Africa with creation of the African Medicines Agency, which really carries the potential to accelerate research in such settings. Thanks.
No, thank you so much. You mentioned, of course, communication as a key and the tool and the effect and impact that social media has these days. And the politicians, of course, who have to convey those messages after checking back with individuals such as yourself. I'm going to do one very quick 30 seconds round for each on that particular point because I think it's pertinent, but I do want to give David, of course, before we wrap up the second round of questions, also get your take and give you the opportunity to get your vision about how we move forward from here. How do we apply the lessons? How do we keep the momentum going?
Thank you. Look, I think enormous progress was made, but now we're moving into peacetime and we talk about lessons learned, but we often forget those lessons quite quickly or we don't act upon them. And so I think the challenge is using some of the unfortunate epidemics we have currently, neglected tropical diseases, AIDS, malaria, TB, and invest to reduce these because it has a number of benefits. Firstly, if combined with surveillance, if you can reduce the background of febrile illness, you expedite signal detection on new emerging diseases. So it makes perfect sense, and there's a benefit for everybody involved in that. You can build capacity, but we need to do it differently. We need to do it in a way where we have shared leadership with low and middle income countries around this. And we need to take the end-to-end perspective that my colleague here from UNITAID mentioned, where we look at all elements of the supply chain from research all the way through to deployment, and determine how can we, and I wouldn't say geographic diversification, I'd say geographic enrichment. How can we actually move these benefits and responsibilities so that they're more shared and we have more resilience throughout the system?
Thank you so much indeed, David. Now, before we wrap up, I do want one very quick rapid fire round, if you will, to tackle a question which, to be quite frank, would deserve a panel in and of itself. And as a matter of fact, we had a fireside chat about the gap, how to overcome the gap between policy and science here. And I just do want to get your take, 1 minute each, knowing very well that this is quite a challenge. Saleh, starting with you. Look, it's at the end of the day, it's people like yourself, experts like yourself, who have to inform politicians, who have to improve perhaps the communication with politicians so they in turn can inform their citizens and avoid the misunderstandings, Johan, and the fake news that you have alluded to. Saleh, how do we improve the communication with policymakers?
I think, Ali, building a system, again, out of the healthcare ecosystem as an emergency physician, we want to look at the emergency management ecosystem. That by itself depends on multifactorial in terms of surveillance, funding, and others. So many components within there. Politicians, I think if you come with evidence and data and very convincing and sounding plan and suggestions, they usually take it. I think their success is your success and vice versa. They would like to succeed. The only thing what I find is just sometimes the message is not delivered the right way. Sometimes it's too technical, so they get lost, or too shallow that they actually don't get it. So we want to work in this emergency management ecosystem where we come in forums like this with multiple backgrounds. We deliver similar to what we're doing now, a G20 messages, very actionable items, simple, easy to digest, but at the same time really tackles the key priorities. That's the way I would highly recommend it. Working with politicians, working with the government, honestly, most of them very positive and genuinely want to care and do care. The only thing is our task, how to deliver the information on the right platform.
And thank you so much, Saleh. And that is indeed the question, right? Isn't it? How to deliver more efficiently, perhaps, that communication. Mary Ainge, what would be your recommendation?
Look, I think it's very important to be clear to them about what are actually the barriers to access and acceptance of, the science and the implication that it can have. If I take the example of the vaccines, for example, really understanding, bringing to them what's happening and what are the impact that it can have. I mean, one anecdote, I was talking to the president of the European Parliament, and he was keen to understand the issues in Africa and the vaccine hesitancy. But the truth is, and Thomas knows, in Gavi countries, previously there was very little vaccine hesitancy because they are convinced about the vaccine. Actually, the coverage rates are much higher in these countries than in Europe, for example. The vaccine hesitancy came with COVID. And why? Because initially they accepted, and then they started getting all these political leadership messages of, whoa, we can use this one and not this one, and maybe there's issue, this one. And I think bringing this up and so that we have an effective communication is important. To the point of Bill, I think we really have to break it down. There's a global messages, equity, and everybody likes it, but what does it mean concretely? What can we do, the two things we can do in the next year to improve this? Of course, concretely, a lot of things we do in vaccine hesitancy is working. For example, with social media, there are a lot of programs in countries to be able to provide more of the benefit and what is happening and so on. But I think it's being very clear, because it's interesting that he was asking me when actually we think most of the problem comes from the political leadership message coming from that part of the world, because before there was no issue.
Absolutely. Interesting to see that the hesitancy or the doubts, if you will, became much more common once the message perhaps got diluted and people were starting to contradict each other. Thomas Kuhne, as the as the Director General of the IFPMA, you are, of course, trained, if you will, to speak to policymakers at the end of the day. What advice could you dispense here?
I think basically we have to understand that we're all in the same boat. Everybody said no one is safe until everyone is safe. But then did we walk the talk? And from our side, I think our lessons learned have received a lot of praise from our partners, but we also have to accept that we need to be humble. Without the support from the G20 and G7 leaders for open borders, that's crucial. It will not work. Europe, I'm Swiss, therefore I can't claim credit for the EU, but Europe never shut its borders. And I think that's what we also need from the others like US and like India, this social contract. And we need to have a commitment from the countries to funding. We can't afford to lose 2, 3, 4 months for fundraising when the world is burning. And we need that support. The companies have shown a willingness throughout the pandemic to do business not as usual, which means to engage in tiered pricing at cost, not for profit, for the low-income countries, to an extent which I would never have dreamed that our companies would do, but they did. And we need support from others that this will work for better equity.
Thank you so much, Thomas. Janet Ginnert, also your final recommendation about how to improve the communication with policymakers so that we're all on the same page rhetorically and in terms of concept.
Sure, thanks. I think there's a lot that's been said about the importance of clear messaging, but I would also say understanding how that opportunity and how the challenge has evolved or changed with the pandemic. And I say that because the messaging doesn't happen in a vacuum. It's happened in a context where this whole pandemic has raised attention on cross-cutting issues like licensing, resilience of supply chains, oxygen, access, and the rest. It's challenged all of us as global health actors to try to speak about health concerns in economic terms real delivery terms, and real world issues. At the same time, it's made certain global health tools and concepts household terms. Things like rapid tests, self-tests, pulse oximetry. These used to be fairly esoteric terms, and now a lot of people have those in a drawer. Contact tracing, I'm glad to see that tuberculosis is on the agenda later this afternoon. Certain things that literacy has evolved, and I think can open up new opportunities if it's not too technical, if it's not drowned out by false information or misinformation, and if we're clear on the sort of North Star guiding light, what our collective goal is for equitable access to these tools. One other reflection, there's been a lot of focus, and this is natural, on the architecture and how we all organize ourselves. And that is very important in a way, and we've talked a lot about that. But if we really consider the people who are going to benefit from this work, the work that we're all trying to do, and if we're putting communities at the center of those efforts and that response, then some of those distinctions fall away. It's not really about one pillar of Act A or another. It's about what happens when someone with a cough or a fever seeks care, what tools need to be available at that point of care, and then what happens next. And so how those country programs are working and able to ensure that best-in-class tools are available, deployed, affordable, in place where they're needed. Thanks.
Thank you, Janet. Bill, also your final recommendation with a specific focus on how to overcome the gap between the scientists and policymakers, particularly with an emphasis on communication.
Yeah, I just want to actually call out the leadership of WHO on this issue in the past 24 months on scientific communication. You know, you asked Johan and Marianne about vaccine hesitancy, and vaccine hesitancy is really just maybe the most visible manifestation of a decades-long trend to question the primacy of science as the basis for public health, right? And I would say in the past 24 months through COVID, the leadership of WHO, and I'll specifically call out Soumya Swaminathan, WHE under Mike Ryan and Maria Van Kerkhove, and the DG, Dr. Tedros, their relentless use of social media and press conferences on a regular basis to convey accurate scientific information to the global community has been the most effective and important way to get the clear message out about the scientific basis for the policies that policymakers can implement. And I think it's important to say that that's something that WHO can and should continue to lead on. That's a critical role, and I applaud the amazing work those 4 individuals and groups, but broadly across other groups, GMP for what they've done on malaria is similar. And the recommendation I would say is moving forward, that muscle that's now been strengthened here over the past years under COVID, I would like to see it not just sustained, but strengthened even further across all disease areas. WHO can lead, Dr. Tedros and the DG and the communications office can lead to say science matters and here's the scientific basis for this. In that sea of misinformation, the voice of WHO is critical and has been critical in the past 24 months.
Seizing upon the momentum that has already been established. Thank you so much, Bill. We have 3 last speakers. Osama, of course, I want to get you in, Johan, and David, then getting your final recommendations and how to improve communication with politicians.
Thank you very much. So we found all the countries in that confrontation or conflict between the politicians and the scientists, and especially in the early stage with the lack of data and information, right? That's why we really have to learn how, what the kind of a gap and what the kind of bottlenecks in that one. So one thing is, of course, collecting the data information, it is very much important. But at the same time, when we don't have a good data, how to just, make a good, explanation and also that interpretation from that reality, right? And at the time, again, we also need some kind of dialogue between a variety of experts, not only scientists, epidemiologists, but also the economists and the education and other people, because the impact is not only health, but education and all others. That is why first we need a real kind of dialogue discussion among that experts of variety of the field and translate into much easier and clear message to politicians. And anyway, we cannot make it real perfect communication. Important thing is what is the real fact. and how to change or evolve that communication. That is maybe quite important one.
Thank you so much indeed, Osamu, for your final remarks. Johan Wekemans.
Thank you. And I certainly agree with the highly important role that WHO has had in as a convening body. I think it can also come from the politicians themselves, with a vision of the sort of leadership and the mentality that they will imprint on programs. I was, based on personal experience, pretty impressed with what happened in the UK at the early time of the pandemic when launching the vaccine development initiatives. It's really the government put people together, what they have best from the academic world, pharma, biotech, and got them to work together. And all these bodies continued meeting relatively regularly. So creating this space of open dialogue is really important. There are some use of barriers and firewalls to prevent conflicts of interest and undue influence. But that's okay. That stays, despite the fact that there are also channels of communication that are created that favor more open and direct communication. That can have a huge influence on the success of program and also on the message that is being sent out there.
Thank you so much, Johan. David.
Thanks. Just two perspectives on this. Firstly, in the countries that we serve, the lower middle income countries, I need to call out groups like the community healthcare workers who day in, day out deliver malaria interventions. They're trusted. And during a pandemic, they're able to deliver messages on the pandemic and actually dispel a lot of the myths. And so using channels like that, and it gets back to one of my points earlier, that this really helps prime the machine and build the capacity for a pandemic. The other is a warning to people like myself. And we can come across as being quite arrogant scientifically. We talk about the facts, and what we're dealing with is emotion. And I think we need to get a lot better at listening to people whose views differ from ours, particularly those who may have vaccine hesitancy, understanding why, and asking questions like, what do you need to see, know, understand in order for you to want this vaccine? So a little less arrogance on the part of the scientists like me, and I'm right at the front of the line, would go a long way to bringing people with us. And it would help governments as well, because they're dealing with a populace with many different views, and just saying these are the facts doesn't help.
Thank you so much. Appealing for greater empathy, as I hear it, on the part of scientists for those who may not be so very much in tune and knowledgeable about these subject matters. Thank you. I think that's an important point. David, let me just point out as we are closing this session, first of all, I want to compliment all my speakers for being extremely efficient in how they delivered their very important messages. We had 8 speakers and still finished finish more or less on time, but more importantly about the substance and the wisdom that you have parted with us here throughout the past 60 minutes, looking at Hatice. I think many messages that you can derive from this extremely insightful session. Want to thank all my speakers, of course, Saleh, Mary Ainge, Thomas, Janet, Bill, Osamu, Johan, and David, for a wonderful session. We started today at 9 and now it's about 12 o'clock. So I think we all deserve a little break here, which we shall get. We're going to have a lunch break now. Come back in the room at 1 p.m. But let's finish off with a big round of applause for our 8 speakers. Thank you so much.